I would like to thank you for coming to this very special 10th annual Cy Frank Legacy Lectureship. It's a pleasure to see such a dedicated group of interested parties to celebrate the remarkable contributions of Dr. Cy Frank. My name is Diane Mosier, and I am honored to deliver the opening remarks in my role as the chair of the Cy Frank Legacy Lectureship Committee. Today, we honor Dr. Frank's enduring legacy of research, innovation, collaboration, and mentorship. Dr. Cy Frank was an orthopedic surgeon, scientist, long-term faculty member of the Cummings School of Medicine, an alumni of the University of Calgary Medical School, and one of the founders of the McCaig Institute of Bone and Joint Health and the Alberta Institute of Bone Health. Internationally, he was known and acclaimed for his visionary efforts. He championed multidisciplinary clinical research and its translation into innovative clinical care. Following his passing in 2015, the University of Calgary and the Cummings School of Medicine established an endowment for an annual lectureship in his honor. The lectureship showcases the work of individuals who reflect his passion and commitment to health innovation. As we celebrate this milestone, the 10th anniversary, we are proud to present a new video honoring Dr. Cy Frank's legacy. This video not only highlights his profound impact, but also serves as a call to action for all of us. It invites each of us to find ways to contribute the spirit of Dr. Cy Frank's work in our own endeavors, encouraging innovation, collaboration, and a commitment to improving health care.
For those who knew him, Dr. Frank was more than a colleague. He was a visionary dedicated to advancing musculoskeletal health. I am Judy Crawford, and for 27 years, I was Dr. Cy Frank's executive assistant. Dr. Frank's career was marked by numerous accolades, including his role as the inaugural scientific director of the Institute of Musculoskeletal Health and Arthritis. He was also named as an officer of the Order of Canada in recognition of his unparalleled contributions to medical research and healthcare in Canada. His influence can be felt in all corners of the healthcare sector, from cutting-edge labs to clinical settings where lives are transformed. The McCaig Institute for Bone and Joint Health, along with the Cummings School of Medicine, proudly supports the Cy Frank Legacy Lectureship, which ensures his vision continues to thrive.
Dr. Frank was obviously a passionate orthopedic surgeon and a passionate advocate for quality healthcare. And he really initiated quality improvement initiatives around joint replacement surgery and access to orthopedic surgery overall. He established the Western Canada Wait Time Alliance and a series of projects that really for the first time looked at how we could bring people through a centralized triage program for joint replacement surgery, which is so important for people living with arthritis. I think overall he was fundamental to a series of collaborations that really advanced arthritis care and research in Canada.
I first met Cy when he put me back together after a sports injury in 1984, and our collaboration lasted over 30 years. So that was a tremendous impact. Cy has contributed to improving patient outcomes and clinical practice in several ways. One of them would be the integration of research into clinical practice and convincing researchers that we should be thinking in terms of bedside to bench and back again, as opposed to bench to bedside. We need to be aware of what the problems are that both clinicians face and what patients face when we're thinking of how to do the most appropriate research.
From the non-invasive diagnostics perspective, the innovations were really important for learning about how we do our pathways. There was a lot of work on how we measure success, and we were looking at using databases that helped us understand how people did with patient-reported outcome measures after their hip and knee replacements, but also whether they came back early or later with complications for that. So that would be the area where I'd say from the non-invasive aspect that he worked on his technologies. So I was very involved with trainees at various levels and actually colleagues and junior faculty. And Sai's approach was to be one of inquiring, one of challenging us about what we think or what we might hold, to always have open minds. And Sai was always in an inquisitive, curious nature. This is a picture, this is actually Sai's birthday. He would come over to our house quite a bit, and this is my wife, Kathy, and my two children, our two children, Kurt and Karis. And so we're celebrating here and having a great time. It's very interesting that both our kids now working here in McKeag, they're PhD students. They work in sarcoma research with one of our orthopedic surgeons in sarcoma, Mike Monument. And Mike was also a graduate student in my lab in some of my research. So I would say I look after Mike, but now Mike's looking after my kids. So I'm grateful for the opportunity, and it's just a handing down of the legacy from Sai ultimately.
Dr. Sai Frank's life and work serve as a powerful reminder that through collaboration, impact, and innovation, we can create lasting change. As we celebrate his enduring legacy, we look to the future. Dr. Frank's work is not just a memory, it is a call to action. Join us as we continue his mission to advance musculoskeletal health and inspire new beginnings.
Reflecting on the video, we're reminded of the incredible legacy Dr. Frank has left behind, and how it continues to inspire all of us. Today, we honor not only Dr. Frank's contribution, but we also want to recognize the many distinguished speakers who have graced this lectureship over the past years. So if any of the speakers are in the audience, if they could please stand up, and we give a round of applause to them as well. I'd also like to recognize Dr. Mar Fritzler, who was the initial chair of the Cy Frank Legacy Lectureship Committee. So without further ado, it is my pleasure to introduce Master of Ceremonies, Dr. Cheryl Barnaby. Cheryl is the Scientific Director of the McKeag Institute for Bone and Joint Health, and she is Professor of Medicine at the Cummings School of Medicine, and most importantly, she is a rheumatologist. So
Okay, well, thank you, Diane, and welcome to everybody. It's very great to have everyone here for this special celebration of Cy Frank's legacy. Oh, all right. So I draw your attention to the university's land acknowledgement up on the screen, which recognizes the Treaty 7 communities, as well as the Otopimiswak Métis government, which I am a member of. I'd like to take a moment to reflect on reciprocity and connectedness. So last weekend, I had a brief chance to fly over to Winnipeg to celebrate one of our keynote lecturers' successful career as well, and had a chance to read a very small book called Serviceberry by Robin Kimmerer, who's an American Indian writer. And we call it the Saskatoon bush here, not Serviceberry, but anyhow, in this book, she highlights the dependence of each being and organism in the innate cycle of nature. There are contributions of soil organisms, the earth, rain, sun, and the insects to help grow that bush. and then the role of the birds to help distribute the seeds for future plant growth, and then finally the humans in distributing fruit so that everyone is fed and sustained. This made me reflect on Cy's strengths as a leader. He recognized everyone had something to contribute in our collective goal of improving arthritis care. By working together, no matter which community we represented, we could achieve great things. In this vein, I wish to express my appreciation for being welcomed here into Treaty 7 territory, which has allowed me to cross paths with Dr. Frank and have my career being guided by such an inspirational and giving human. So miigwech to Dr. Frank. I'm going to move on to housekeeping notes next. First, you're going to notice an artist at the back of the room whose name is Jolene from Drawing Change. Some of you who've been SCN participants will remember graphic recording of the meetings, and we wanted to do that today as well to create a visual representation which will be brought over to the McCaig Institute and placed as another commemoration of today's event. There will be several opportunities for Q&A today, and we'll be using Slido to facilitate that. So you can either enter the code on the Slido app or scan this QR code, and we'll also have this placed in the lobby for you to be able to join it. When you're submitting your question, it'll be through this app, and then we will be able to direct who that question is to appropriately. You can submit the question at any time during the talk, and if you're having trouble with your mobile device, you can also just write it on a note piece and give it to Karen, who's at the front here waving her hand, and we'll also get your questions addressed that way. This lecture is being recorded, and it will be shared via email to every registered attendee after the event. And finally, if you are looking for the washrooms, they are just outside down the hall to the left from here. All right, so now I'd like to introduce our first speaker, who's Dr. Hani El-Gabalawi from the University of Manitoba. Dr. El-Gabalawi is a rheumatologist and professor of medicine and immunology, now emeritus, I think. I'm not sure what the official title would be. Clock just turned over here. But he has also held the Endowed Rheumatology Research Chair and was previously a scientific director for CIHR's Institute of Musculoskeletal Health and Arthritis. And he'll be speaking to us today about return on investment in biomedical research. What you measure is what you get. Please welcome Dr. El-Gabalawi.
Thanks very much, Cheryl, and I must say I'm a little bit nervous here. This is my alma mater. 50 years ago, I was walking around these halls as a medical student, and I'll say more about that in a moment. But I really, it couldn't be a bigger honor for me to be presenting this lecture. So thank you to all those who I can readily acknowledge because I've spoken to them, and those who work behind the scenes to make this happen. Okay, so the outline of my talk is going to be the following. I'm going to have a few reflections on my personal interactions with Cy over the years, starting with our days as medical students together, and then talk about the Canadian Academy of Health Sciences framework indicators to measure return on investment in health research. I think many of the people in this room are probably quite familiar, probably more familiar than myself. It's not my area of expertise. But I really want to spend the time looking at two exemplars I'm familiar with. One which occurred during the time, or started during the time when I was scientific director, as I mentioned, following in Cy's footsteps. And then the other is my own research program at the University of Manitoba. So my personal reflections with Cy, we go back a long way, half a century, it's hard to believe. But in those days, there was University of Calgary was young. We were the 5th graduating class. Excellent faculty to student ratio. There was a freshness and a newness about the medical school compared to, I'm not going to kind of take shots at University of Alberta, University of Manitoba, or these well-established. But the University of Calgary has a freshness there. And each class got to be named by the class before them. I think that tradition is still there. Cy's class of '76 was the Beavers, and it's probably a good name for them. They were, keen, athletic, and we were the Toads, and I'm not sure what that says. Marv, what was your class? We named ourselves the Golden Eagles. There you go. So it was a great tradition. I don't know if they're running out of animals now after this long, but okay. And so subsequent to that, I went and trained in orthopedic surgery and research and data, and I followed the internal medicine rheumatology path. And we really didn't cross paths again together until early in 2000s when the Canadian Institutes of Health Research was born. The Medical Research Council got kind of transformed into this institute, the institutes that were focused on health as opposed to just basic biomedical science. And I was involved in some of the administrative aspects of that early on, and Cy was selected as the inaugural scientific director of the institute. And I had the privilege of serving on his institutional advisory board during that time, and I can tell you he's just amazing. You all know that, but he was truly amazing. But a word about the institutional advisory board structure. Now it's done virtually. And when Cy did it, when I was scientific director, we'd go to places all around the country, we'd meet researchers, so there's something been lost there, and I hope that CIHR sees fit to bring back the in-person IAB meetings. That's a little plug. Okay, so subsequent to that, I had the great privilege of getting appointed as a successor to Cy as scientific director of IMHA, and I got great wisdom from him. I remember sitting down, having a beer with him, and that's when that term that's in the title, "What you measure is what you get," came from, and I'll explain a little bit more about that. And then we all know about his untimely passing. Okay, so let's switch over to the second part of the talk, which is the framework that was put together through the Canadian Academy of Health Sciences, which was formed in 2004, and the fellows that were inducted into it, their job is to, in their words, to provide scientific advice for the health of Canadians. And they would put together panels of experts, multiple experts, multiple disciplines, to address questions that were important to Canadians about health and how research is impacting on health. Now, Cy led or chaired a panel which was probably the most influential, at least in my opinion, the most influential panel that the Canadian Academy of Sciences had, which is on making an impact, the return on investment in health research. And you can see here the members of that panel. And this was sponsored by multiple funding agencies around the country. I'm sure you'll recognize many of them. Some of them you may not recognize. But 23, it's actually more than 23, but the 23 in total actually sponsored this. And they all had their own idea about what they wanted return on investment from the dollars that they put out to researchers. And one of the key accomplishments of Cy's panel was to actually emphasize that we can't have multiple ways of measuring impact. These have got to be measured in standardized ways that can be applied across the board. So why measure return on investment in health research? There's been an ever-increasing funding of health research, both through provincial, federal agencies, private investments, and so on. And the public at large has increasing expectations. They want to live longer, they want to be healthier, they want to have better quality of life, they want the decisions that are made about health to be informed policies, economic benefits, commercialization, attract talent, build capacity, and readiness for health threats, as we've appropriately seen in the COVID-19 pandemic. So these are the expectations. These are lofty expectations of the health research enterprise. Now this is, I would encourage you, those of you who actually haven't seen the report to look at this, but this is a simplified version of basically what it says. You generate research activity, you advance knowledge, you build capacity, and through that you inform better decision making, and then that loops back to the actual research. That informed decision making leads to health impacts, which, as we'll talk about in a minute, is much harder to measure, actually. And then ultimately, the broad economic, social impacts of these health impacts. So these 5 domains are key to the whole research enterprise and how we evaluate it. And this is just kind of a laundry list of what falls under each of those categories: advancing knowledge, the kind of things we're used to, papers, citations, methods, intellectual property, and so on. Building capacity, researchers, infrastructure, human capital, informed decision-making, guidelines, policies, public knowledge, and then the impact on disease prevention, treatment, improvements in health, quality of care, health determinants, and arguably one of the more difficult things to measure is the economic and social impacts. And as we shall see, there's some great experts here in the room, Dr. Deborah Marshall. She actually lent me a lot of her slides, so thank you, Deborah. Okay, so how do you use the framework? You apply it, you define the prioritized evaluation questions when you try to look at the impact. You select relevant impact categories and the levels that you would want to study and evaluate. You choose appropriate indicators and metrics. But we have to face the fact that many of those metrics are not there. We don't know how to measure all of the real impacts, the societal impacts, and that's really emphasized in the report. Some of the metrics are quantitative, some of them are not quantitative. Recognize the attribution challenges and misuses. You attribute something to the funding you got there, whereas it's obviously a much more complicated picture as to what that attribution should be, and tailor the evaluation to context and objectives. So that's a whirlwind through what the report said. Again, I would encourage you to have a look at it. There's a lot of really interesting information. What I want to do for the rest of the talk is apply it to 2 exemplars that I'm most familiar with. So the first was when I was in 2014-15, when I was kind of starting out, my first couple of years as scientific director, we had discretionary budgets, strategic budgets, and we could use them as we saw fit. And this was kind of about 30% of CIHR's budget is given to the institutes to do with, and they encourage institutes to work together and so on, and then the rest of the 70% is open competitions. So I had some colleagues in the Netherlands, and I was visiting them, and they said, well, what about trying to do something with both countries that may change clinical practice on rheumatic disease? So I had the privilege of meeting the director of ZonMV, which is the CIHR equivalent in the Netherlands, Henk Smeed, who is a fabulous person. I spent the day with him, we had dinner, and we talked about it, about funding a transatlantic network in rheumatic disease research. And their model there is that there's insurance companies that put money into the government for research, and those insurance companies want return on investment. They want better ways of treating people, cheaper ways of treating people using, they were funding a lot of cancer medicines and biologics that were just kind of coming on stream. So they were very interested in this area. And we managed to get Rheumafond, the Dutch Arthritis Foundation, agreed to participate, and we tried to get the Arthritis Society, but they had already committed to some large initiatives. But as we shall see, they made more commitments later on to the successful initiative. So we were able to put together $8 million for a single network. Canadian funds were spent in Canada. Dutch funds were spent in the Netherlands. And we asked rheumatic disease-based groups to apply. The rheumatoid arthritis groups, their colleagues in the Netherlands, colleagues in Canada, the JI, juvenile idiopathic arthritis, myeloneuropathies, scleroderma vasculitis. And then we asked the leadership of these groups, the Dutch leadership, the Canadian leadership, to come and present on behalf of their group in this kind of very dark and almost austere hotel in Amsterdam. And it was a great international peer review committee chaired by Dr. Alan Silman, who some of you may know is fabulous. And I was there as a funder. You know, obviously I couldn't peer review, but it was really interesting to see the different presentations. The juvenile idiopathic arthritis group was a clear winner. I say that without hesitation. And there was some very, very excellent groups. They're doing amazing work. But for a transatlantic network, these folks had worked together before, they had cohorts, they'd published together. You could sense no forced marriages there. These were people that were gonna produce results. Okay, so that was the foundation of UCAN Can Do, Canada Netherlands Personalized Network, a medicine network in childhood arthritis and rheumatic disease. You can see the funders there. Leads in Canada, Dr. Ray Young, and in the Netherlands, Dr. Nico Wolfrapp. And I think many of you know that Dr. Ray Young was just appointed the scientific director of the Institute of Musculoskeletal Health and Arthritis, following in the wonderful tradition of Cy as the inaugural scientific director. You can see here Dr. Deborah Marshall, the health economics aspect of this, because real key to showing the return on investment. A subsequent funding opportunities, they built their, people were throwing money at them, basically. It was incredibly successful. Arthritis Society, Genome Canada, University of Calgary, University of Toronto. And with a related initiative, UCAN Care. And this is the idea. They built basic science resources, everything from platforms, bioinformatics platforms, all that was needed to do highly successful science, then generating knowledge to understanding the exposome, the microbiome, the epigenome, and so on, and ultimately the impacting on healthcare in that these would give insights into how we change practice. So with the specifics in terms of the juvenile arthritis, they wanted to address gaps in the treatment, support translational research, children with JIA, focus on the development of new concept for standardized evaluation of disease outcomes, e-health tools for clinicians and for patients, and integration of the biological profiles in decision-making and clinical and policy. So, these are, you think back on what we talked about, the framework, this is exactly what Cy and his panel envisaged. And it would work something like this. They had cohorts in Canada, cohorts in the Netherlands. They collect samples, they collect clinical data, patient and parent-reported outcomes. They have platforms, digital and e-health platforms, data science, analytics, so on. A lot of outstanding biomarker research to look and categorize children, putting together insights about their clinical presentation, along with the biomarkers that are measured, and ultimately looking at the integration with health economics. How does that change practice? How does that improve the health? How does that save society valuable dollars and improve the life of children with arthritis? And this is the tool, this slide I got from Dr. Marshall, just showing how overlaying the health economics and socioeconomic benefits of these precision decisions that are made based on the studies that are done, both clinical, basic science, translational, in the context of this. And this is the vision, is that you get a child with arthritis. They see a rheumatologist. Treatment is initiated in a timely manner. Appropriate treatment, appropriately targeted. At some point, the treatment is stopped. By identifying the people, you can actually stop the treatment down without having disease flare, and ultimately limiting the disease activity, limiting the damage, and mitigating a lot of the economic burden associated with it. So this is the 5 categories we showed you. And again, this is a slide that was donated to me by Dr. Marshall, and I'm not going to read everything in there, but clearly that there is accomplishments that are relevant to each one of those categories that the panel identified as key for their research impact. Okay, how much time have I got? Let me switch gears now to the work perhaps I'm more familiar with, which is our own work at the University of Manitoba on prediction and prevention of rheumatoid arthritis in First Nations people. We have been fortunate to receive uninterrupted funding from CIHR since 2008. So return on investment is a big theme when you've had that much money. And it's not that much, but clearly we have had wonderful support from CIHR, and it's very important that we demonstrate what we need to demonstrate. Why study rheumatoid arthritis in First Nations people, Indigenous North Americans? This table, I don't know how big you can see it there, but you can see in many, if not most, Indigenous North American populations, the prevalence of rheumatoid arthritis is substantially higher than you probably see anywhere else in the world. And we have studied the First Nations people in central Canada, and many of the people in this room have been involved in that research. And we've shown that the prevalence is 2 to 3 times higher in First Nations people compared to pretty much any other population. The age of onset is 10 years younger. So you've got 10 years more disease to accrue, damage, and all the things that rheumatoid arthritis does. Now, in First Nations people in the Cree Ojibwe population that we've studied, it is almost all what we call seropositive disease. There's antibodies associated with rheumatoid arthritis compared to Caucasian populations where only 2/3 of the population have antibodies, and the others have the so-called seronegative. Now, this becomes important because these antibodies can be detected months to years before the disease starts. And this has been our real hook on trying to get preventative strategies. In addition, First Nations people have more large joint involvement. Those of you familiar with rheumatoid arthritis tends to affect the small joints, the hands and the feet, wrists. They also affect the large joints, but much more commonly in First Nations people, we see things like shoulders, elbows, knees, disabling joints. And this is reflected in a tool that we use in clinical medicine called the Health Assessment Questionnaire, which assesses disability. And cohort 1 is the early cohort, mid-cohort, and then people with advanced disease. And what you can see is as the disease advances, the First Nations people accrue more damage and disability that impacts greatly on their life. So this is the paradigm that we followed. These antibodies appear years before the disease actually starts, and we can detect it through gene-environment interactions. There is a break in immune tolerance, so we get what is called benign autoimmunity. That autoimmunity gets amplified and evolved in some individuals, not all. And our data and the data of others has clearly shown that some people develop these antibodies and they go away. Some people develop antibodies and they never get disease. But in some people, that immune response is amplified, and it reaches the point where it starts to target the joints, and then symptoms start to occur, and then the clinicians can actually identify this is rheumatoid arthritis. We see it, and by that point, you got lifelong disease. And it's very difficult to turn this off. Okay, so why study RA in preclinical RA in First Nations people? High prevalence, I already showed you. Severe disease showed you. Familial disease, some nice work we did with Mark Fritzler, studying the first-degree relatives. And there's familial clustering. You know there's familial clustering of genes, but we showed with Mark this familial clustering of cytokines that are circulating in the blood. So there's something about the family members that increases their risk, not just based on their genetic background. Unfavorable outcomes, complex interactions between biological, sociological, healthcare delivery factors. Just think about this. If you got diagnosed with rheumatoid arthritis, new rheumatoid arthritis in your First Nations versus a non-First Nations person at the same age, your mortality as a First Nations person is 20 years younger. That's huge. And that needs to be addressed in a very meaningful and significant way. So it's a perfect storm of interactions. There's lots of genetic prevalence, genetic predisposition, and the environmental factors. We've studied a lot of gum disease, which is strongly associated with the onset and with the severity of rheumatoid arthritis. Smoking, probably the best defined environmental factor. And CIHR funded us to get the RA programs, the First Nations people with RA, but we don't follow them because they're already being followed in clinics and so on. And they bring their first-degree relatives in, and then we enroll them in the study, and we follow them longitudinally, and we assemble an at-risk cohort who have the autoantibodies, and we follow them to see who develops disease, who doesn't develop disease. So you can see that added benefit of this, even if we never got to see the individuals who develop disease, if they develop disease, there's early access to the most state-of-the-art interventions, which in itself is a great accomplishment, we think. These are the communities we worked in. We work in the urban community in Winnipeg, 2 northern communities at St. Teresa Point and Norway House, where we've done a lot of our work. And then we had worked with a collaborator in Alaska, Liz Ferrucci, who worked with the Tlingit people there, and the late Janet Markland with First Nations in Saskatchewan. Okay, so how does this work? You got to show up. This is not the kind of thing that works on Zoom. You got to go to the communities, and you got to talk to the chief and council, and there's some really key elements of truly engaging in a partnership to get this work done. But it has its challenges. This is, you can see there, that's the Perimeter Airlines that we take up there, and it's not what we're used to, but it was, they're actually quite a safe airline, and they've never had any bad. And in the middle frame there, that's the airport at St. Teresa Point. It's on an island. So if you land in the winter, you can just drive across the lake and everything's good. But if you land in the summer, you got to wait for a boat. You can see in the bottom corner there, we have all our boxes and so on. You try not to do it in between seasons. You could see that truck drive, and we were assured there was at least a few days left for the ice. That was reassuring. Yeah? And so fortunately, we've never had any mishaps and so on. Research agreements are an absolute key. And they're an accomplishment in themselves. They're an impact in themselves. To be able to work out research agreements with the communities based on the principles of ownership, control, access, possession. And you have to work one out with each jurisdiction. Okay, it's not to say, well, we got an agreement with Norway House, so it's going to work in St. Teresa Point. So we got each jurisdiction. They need legal review. Our institution, university, represents us in this process. We have advisory bodies, elders, health leaders, and so on, and amendments when needed. And these are 2 agreements, one with St. Teresa Point and one with Norway House, written very differently, by the way. One was written by the health director, the other was written by the chief in Norway House. He was a lawyer. And the tone of them is actually quite different. But they embody a lot of the same principles that are important to undertake. Okay, just a very quick list of things that we've found make a very big difference. Number 1, a local community collaborator, typically a health director, and I have to give a shout out to Florence Duncan in Norway House, who's worked with us for years. She is absolutely awesome. And I don't know why she hasn't retired. She's older than me, and I'm old. So Florence has been absolutely awesome to work with. Local research assistants who can be trained in a study methodology and who are well connected with the community. In conjunction with the research, providing clinical services to the community. So you go up and they do outreach clinics. And Dave Robinson, my colleague from University of Manitoba, he's been going up for 25 years, everywhere from to Arviat, to Rankin Inlet, to Norway House, I think this is really a key aspect, is enhancing the clinical services. Sharing results, essential for ongoing goodwill. And we made the mistake once of informing all the people that were autoantibody positive, but we forgot to tell the people that were negative. So we got our wrists slapped because, you got to tell everybody their results. And we learned our lesson. Plan for dealing with incidental findings. All of you who do clinical research like this, you find, a blood sugar that's sky high, hypertension, whatever it is, you have to be able to deal with that in these communities because it's important. And harnessing the power of the local radio station, that's something that I absolutely, we'd have talk-in shows. Go into the local radio station, and we say a little bit about the study, and then we open it up, the phone lines. And, you get to predict the questions. Well, what does the weather do, and what am I eating, and this. But it truly is an amazing opportunity to engage the community and to have an exchange with the community. We'd have meals in the evening as 3 people would come. The local radio station. Timing of the research visits around health fairs is quite important because everybody is there. I'm just going to show 2 slides from probably our most important finding. In the progressors, these are 18 people who developed rheumatoid arthritis after we followed them for years versus the majority who were non-progressors. The progressors were younger, not older, younger. And their BMI, there's a controversy in the rheumatology literature, is obesity associated with rheumatoid arthritis. They had lower BMIs, folks who progressed, and virtually no type 2 diabetes, so we couldn't show any association there. In this table, there's 4 columns. One is double negative when they came into the study, no autoantibodies. Second is positive rheumatoid factor, positive anti-citrate protein antibodies, which is the hallmark of RA, and then the double positives. And as you would expect, the cases of inflammatory arthritis per 1,000 years, if you're double negative, it's 4. If you're double positive, it's 97. So your risk is much higher. And the latency, if you're double negative and you develop rheumatoid arthritis, you have to wait 5 years. If you're double positive, it's 3 years. Okay. So the holy grail of the research, and this is a huge international agenda now, is how do we prevent autoimmune disease? And what can be done to prevent RA in First Nations people? So this is one of the health fairs we had in Norway House a couple of years ago in the local arena there. And everybody come to the booth, and we developed a dry blood spot, and the group here is very interested in that because that's a game changer. You can do a dry blood spot, you can put it in an envelope, you can send it, and I know Diane Mosher and May Choi and others are very interested in doing this for a wide swath of autoimmune diseases just because of its scalability. And that's me performing that. They call me biohazard. They try to keep me away from that kind of thing as much as possible, but you can see there all the ones, all the dry blood spots have been gathered, sitting in the penalty box, and we take those back to Winnipeg with us. So once we identify people who are at risk, this is from a recent review, you want to treat them with something and then take them off whatever you treat them with and keep them in remission or prevent the disease. That's true prevention. So the red line is if you do nothing. The green line is true prevention, where the disease doesn't come back. And there's 2 lines in the middle. One is that you have a transient kind of prevention of disease, but then it comes back and the curves come together. And the other is the disease happens, but it's milder. It's milder disease. So both of those are outcomes. I'm not going to go through this. This is multiple clinical trials that have been done with drugs we use in rheumatoid arthritis. You may be familiar with those. Methotrexate, abatacept, 2 back-to-back papers in Lancet last year with abatacept, showing a lot of promise. But most of what we've seen is delay. You delay the onset, you don't prevent. So we got interested in nutritional supplements, and 3 in particular, and I don't own any shares in anything here, but the 3 supplements are vitamin D, omega-3, and curcumin being the most important. The active ingredient in turmeric's been around for 4,000 years in Ayurvedic medicine. And we had an animal model, a mouse model, where you induce something called collagen-induced arthritis. You immunize them. 3 weeks later, the mice are all hobbling around. But if we use the combination of this, there's a dramatic reduction in the onset and the severity of their arthritis. So we wanted to translate that into human beings. And we designed a clinical trial, which is a crossover clinical trial. And then we thought, okay, back, we have to wait 5 years for the disease to happen. It's hard to power a study where you got to wait 5 years for somebody to get the event. So what we're doing now is we're looking at an open label study to define new biomarkers that are going to tell us we're actually doing something. And I'm not going to bore you with things like glycosylation of the immunoglobulin and so on, but that's the idea, is you want to treat and you want to show that you've reduced risk without having to wait for the event to occur. Okay, the framework, we're going back to the framework, advancing knowledge, novel biomarkers to predict the progression, delineating symptom complexes that are most closely associated with the RA development, testing nutritional supplementation at risk development, building capacity, training basic and clinical researchers, and we've had some fabulous First Nations students. One is the best, arguably the best student I have ever had. And she's not coming here. She's staying right where she is. Okay. And mentoring early career researchers, RA prevention, Indigenous health research, developing research infrastructure in the communities, informed decision-making. We're part of an international group now looking at stratifying risk, enhancing the community's knowledge, and of course the health impacts. You know, these are aspirational. If we can actually reduce the risk of developing RA, that's huge, with the economic impact being, massive. Okay, in conclusion, what you measure is what you get. And we don't know how to measure a lot of what we achieve in biomedical research, and I think we got to start thinking in a very insightful way as to how to measure the real impact of these programs. And measuring impacts thoughtfully and carefully not only demonstrates returns, but shapes the research priorities themselves. This is the long list of people who are responsible for putting this together, and thank you, Sai.
Okay, thank you for that excellent presentation. I'm going to put up the Slido link again if anyone has questions. Hanny, you have to stay. Oh, okay. I could take your questions maybe, but all right. Does anyone want to start? And if not, maybe I could just ask first, how do you measure the quality of the team that you've put together, and how do you assess the dynamics and the building of all of those different voices in the research that you're doing?
Wow. Well, we get help. And we get, so one of, I have to give a shout out here to Elder Margaret Lavalley, who, Margaret has been, she's the elder in residence at the University of Manitoba. She's well into her 80s. Her health is failing, but she has been working with this project for 15 years. And she gives us a perspective on what we're doing right, what we're doing wrong, and what we could do better. So I think getting that kind of advice really makes, especially working in this area, really makes a big difference. When you travel to the communities as a team, you soon get to find out who is a good team player and who's not, right? You know, when you're working in that environment, and often under a lot of time pressure, you know, the flight's going away, leaving at 5 o'clock, and so on. So the quality of the team really shines through when you got to, you know, there's hundreds of people waiting to be screened, and then making sure all the samples. So, I mean, I don't know if I've answered your question, but it's a tough thing to measure, yeah, for sure. Yeah.
Great. So the second question here is, in a resource-starved system, how do you ensure funding research remains a priority for government decision makers, and what message has been most successful in that regard?
I think that the most, governments, by their nature, listen to people. And I think convincing governments through advocacy from patient groups, from communities that have benefited from the input that they've had through the biomedical research, I think that's probably the most potent form of advocacy that may well impact on the decisions to sustain. I mean, we all know how difficult it is to get research money, right? It's incredibly competitive. And I was talking to Roman earlier, Roman Krawitz, about, we spend half our life begging for money, because that's what we have to do, right? And so there's a process, but as you increase the pool of funding that's available to the researchers, you improve the chances, you fund more, better research programs, and I think it's no secret to anybody that we may get even increased application pressure now for the scarce dollars because of what's happening south of the border. So I think that these are all potent messages that hopefully will translate into, in an age of austerity. Our governments are telling us that things are not what they used to be, and yet we all recognize that we need this funding to keep the advancements going.
And I'm just going to ask one final question here. There was lots that came in, but time says we'll go short here. How do you go from having the big idea for such great change in an area that's needed to actually implementing it? Where do you even start?
Okay. Well, you start with advice. You start with feasibility. And and I have to look back at our own, obviously, at our own research, because I'm most familiar with that. You start with your partners. And if your partners are going to be working with communities, you better make sure they're on board. You got an idea, so you look at the rheumatoid arthritis is really bad in your community, and we think we can devise ways of preventing it. Well, if you do that, then not much is going to happen unless the community's on board. And not much is going to happen unless your institution supports you in moving the agenda ahead. So getting the money through a competitive grant is where it starts. But actual realization of the objectives that you aim to undertake involves a huge number of people, administrative people. We have to work with basic scientists who are going to do all of the heavy lifting. And I mentioned the biomarker discovery as it relates to not waiting for 5 years to see if somebody develops rheumatoid arthritis or not. That's all uncharted territory, and you've got to integrate that into the clinical and translational research that you're doing in conjunction with the community. So the implementation, and I have to just, so can I take the opportunity to say this? When I was with CIHR, there was a program that was incredibly successful that was funded primarily by the Institute of Aboriginal People's Health, and it was called Pathways to Aboriginal Health. Can't remember what the exact name for it was. But the wisdom behind that is it started out with small, easy-to-get grants. And if you can demonstrate that could work in a community, then you get a bigger grant. And you say, I can work now in 2 or 3 different communities. And then if that was successful, then you could get a really big chunk of money and work in multiple places. And I really like that concept. I'd certainly like to see more of that. So, yeah.
Great. So thank you so much, Hanny, and I'd ask everyone to give him a round of applause. Thank you. right, it's now my pleasure to introduce the Cy Frank Rising Innovator Awardee. He's just rolled in right on time like a surgeon. Excellent. Newly established this year, this award recognizes a trainee whose research reflects Dr. Frank's enduring legacy in musculoskeletal health. It celebrates innovation, multidisciplinary collaboration, and translational impact. The award attracted a strong field of trainees conducting bone and joint health research here, and ultimately the winner was Dr. Gareth Ryan, an orthopedic surgery resident in Dr. Prism Schneider's lab. Dr. Ryan is completing his PhD research on systemic biomarkers and fracture healing with a focus on tibia and femur fractures. His work also explores accelerated healing in patients with traumatic brain injuries. So please join me in welcoming our 2025 Cy Frank Rising Innovator Awardee, Dr. Gareth Ryan, to the stage.
Thank you for the introduction and for the opportunity to present today. So, like Dr. Barty mentioned, my name is Gareth. I'm one of the ortho residents, also doing a PhD kind of during my residency under the supervision of Dr. Prism Schneider. So a lot of my research is focused on fracture healing and predicting impaired fracture healing, specifically using systemic biomarkers. And there's two different populations that we're looking at. So those that heal faster, and that's the population with a traumatic brain injury. And then those that experienced impaired fracture healing and are more likely to go on to non-union. So I'm going to be presenting some of the pilot work in that second group. So we'll start off with a case. So this is a healthy 26-year-old male who's involved in a motorbike crash. He comes in with this closed femoral shaft fracture. It's his only injury. You take him to the operating room on admission day, and then he does quite well. You see him at 2 weeks and looks as expected, no callus yet. See him at 6 weeks, maybe making some callus. See him at 3 months, not much going on. 6 months, not much improvement. And 9 months, no improvement. So we can all tell that he hasn't healed by 9 months, but the question is, at what point were we confident in making that diagnosis of an impending non-union? So non-union is a failure of a fracture to heal, usually diagnosed by 9 months. And it's quite common in orthopedics, up to about 14% of femoral shaft fractures. And it results in poor outcomes, high costs to patients, and high costs to society. And one of the difficult things is that it's really hard to predict who's going to go on to non-union. We have population-based data that tells us there are certain risk factors that predispose people to non-union. And these are incorporated into different clinical prediction tools, such as the non-union risk determination score, the FENR, and the LEG-NUI. But again, these are all based on population-level data, not patient-specific. And the use of X-rays in diagnosing impending non-union is quite limited prior to about 3 months when we start to see calcification of the fracture callus. So before that, it's really difficult to tell how healing is progressing. And even at that 3-month point, it's only about a 50% sensitivity and specificity in predicting non-union. So this brings in the question of whether there's a role for a precision medicine approach to identification of impending non-union. So this pilot work looks to determine variation in biomarkers related to fracture healing over time. And we hypothesized that there would be considerable variation, temporal variation in biomarkers over the healing process. And then our second aim was to see if there were differences in biomarker levels at different time points between patients with normal healing and those that experienced delayed healing. We hypothesized that there would be a difference. So this was a secondary analysis of previously collected samples from a population from Foothills Hospital. We looked at patients between age 18 and 65 who had an intermedullary nail of a femoral shaft fracture, and we excluded patients with severe open fractures. So we collected baseline data at time of presentation, X-rays starting from 6 weeks post-op until union, and then biomarkers were analyzed from blood samples collected at 2 weeks and 6 weeks post-op. We measured fracture healing using a definition of union as an MRUST of greater than 12, so that's a scoring system used to quantify fracture healing. We defined patients who underwent rapid healing as those with abundant callus formation at 6 weeks on their X-rays. Delayed healers were patients who weren't healed by 6 months, and then non-union patients hadn't healed by 9 months. The biomarkers we looked at were a combination of plasma and serum markers, including leptin, BMP, PDGF-beta, IGF-1, and collagen 10. And these correspond to various stages of the fracture healing process, and these are measured using ECLIA and ELISA. So there were 16 patients included in this pilot study. The average age was about 35, and the majority of them were male. Most of them were an isolated injury, and the majority were treated with an antegrade femoral nail and allowed to walk weight bear as tolerated immediately post-op. We had about a 20% lost follow-up rate. So looking at our fracture healing results, the mean time to union was about 6 months. 3 of our patients, so 18%, went on to non-union. And we found that age, sex, and injury severity score were not associated with rate of fracture healing. These two plots are just showing increasing MRUST scores over time, as well as increasing proportion of patients who are healed at each time point. For our biomarkers, we found a significant difference in PDGF-beta between the 2-week and 6-week time point, but no other temporal changes between the biomarkers. However, they were all readily detectable at both time points in all patients. In terms of the relationship between biomarkers and fracture healing, we found that patients who experienced rapid healing, so callus by about 6 weeks, had a lower BMP2 and a higher collagen 10 at that early 2-week time point, and then a lower collagen 10 was seen in the patients that went on to non-union at that 2-week time point. 6 weeks were a similar result in the rapid healers. In terms of time to union, we found that higher BMP was associated with a longer time to union, and that a higher IGF-1 or insulin growth factor 1 was associated with a shorter time to union, so faster healing. So in this study, we found that all biomarkers of interest were readily detectable. BMP2, IGF-1, and collagen 10 did show promise as potential biomarkers of fracture healing. Specifically, we found that collagen 10 is lower in patients who go on to non-union as early as 2 weeks post-injury. And these biomarkers may provide a reliable early metric of fracture healing. So there are a few limitations of the study. It's quite small. It's only 16 patients, although we did have a relatively high non-union rate of 18%, so that gives us a sizable non-union population. We also only looked at 2 different biomarker time points, just the 2 weeks and 6 weeks. And then, of course, there are numerous other biomarkers that are related to fracture healing, and we only looked at a select few. So in terms of my ongoing research, we have a larger prospective version of this study that's we're currently enrolling for. We're aiming for 100 patients, so we have about 57 right now. We're following them out to a year. We're also looking at a separate cohort of patients with a femoral shaft or tibial shaft and a concomitant traumatic brain injury. And the goal is to compare that group to normal healers and impaired healers. And then finally, we're looking at coagulopathy in both patients with isolated tibial shaft and femoral shaft fractures compared to patients with a concomitant traumatic brain injury. Thank you very much.
It's excellent work. I'll just look to see if there's one question for Gareth, if anyone's entering any. Aria, go ahead. I'll repeat it. Yeah.
So, in these patients that you see there in that non-union, that there is that non-union, how would you go about treating them afterwards?
Yeah, so it's complicated. It depends. There's lots of different types of non-union, and it's either like a biomechanical issue or a biologic issue. Those are the main 2 subtypes. It can also be infection. And yeah, you tailor your approach depending on the type of non-union. Yes. Yeah, so that kind of goes along with the first question. So like looking at biomarkers, specifically focusing on biologic impaired fracture healing. So these are patients who are, let's say, like smokers or diabetics, patients who have severe open fractures and devitalized soft tissues. Patients who have biomechanical issues, it's a separate process. So in terms of like what you would do with the results. I don't think anyone is going to offer a second surgery at 2 weeks based on elevated biomarkers, but it prompts you to say this patient's at considerably high risk of developing non-union, and it would prompt you to potentially order additional investigations, looking like vitamin D, calcium, maybe helping with smoking cessation, or seeing if there's any other modifiable risk factors, and then you may change your follow-up interval with the patient as well.
Okay, so I think you all agree the future is bright. Thank you, Gareth. We're now going to pause for a short break. There'll be time to ask more questions of either presenter, have a small stretch break, network. We're asking everyone to return for 2:10 p.m. So that we can continue the program. Thank you. Okay. All right, so I'll welcome everybody back. We're going to move on to the next part of the program. And it's my honor to introduce Dr. Braden Mans, who has graciously accepted to moderate our next panel. Dr. Mans is the Associate Vice President for Health Research and also the Senior Associate Dean of Health Research at the Cummings School of Medicine. He's a professor of health economics and also a nephrologist or kidney specialist, and he focuses on the cost effectiveness of healthcare policies. He holds a CIHR Foundation Scheme Award and has extensive experience in health system administration. And so please join me in welcoming Dr. Mans.
Thanks, Cheryl. Cheryl and I curl in medical curling on Sunday nights together. That's our main link. At one point, we were winners. So it's a real pleasure to be here moderating this panel. We all have memories of Cy. I have distinct memories of his mischievous smile. Often late at night after meetings, he would have some sort of mixed drink in his hand. His principles have been mentioned throughout the day today, and we're going to see those principles in action in the 4 speakers that I'm going to introduce very shortly. Mentorship will be probably the principle that our first presenter really embodies. Solutions-focused, outcomes, value, you've heard that today, patient-centered, collaboration, learning health systems. You're going to see that within all of the speakers. Cy's fingerprints are over the speakers and the work that is going to be presented. So just a reminder, you can, I think maybe if I advance the slide, yes, if you haven't already, download the QR code. You can put your questions in. Please address them to which speaker you'd like to answer them. We'll collate those. We're going to do question and answer at the very end. I'm going to introduce all 4 speakers. Don't applaud as I introduce each one. We'll applaud after I've introduced all of them, and then we'll have all of the panel speakers come up. The questions will be at the end. So Kristen Barton is a physician who was trained by Cy, mentored by Cy. She's now an orthopedic surgeon, finishing a fellowship and an adjunct professor at Western University in Chicago. Her research is focused on sports injuries and the link to osteoarthritis. Then we're going to hear from Dr. Nick Motati, a colleague of Cy's, an orthopedic surgeon and clinical professor at the University of Calgary. He's the co-medical director of the sports medicine clinic at the university, and he's a leader in orthopedic medicine, keen on patient-reported outcomes and clinical trials. Next will be Dr. Deborah Marshall, a professor and the SFAR chair in health economics, value and impact at the university. Her research evaluates the value of healthcare programs and socioeconomic impacts of health and healthcare. And finally, to wrap up, it's Tracy Wasilek, who I spend a lot of time with over, 5, 6 years as we co-led the strategic clinical networks. So it feels awkward to say that she's a senior policy advisor with Health Canada. I remember all the time we spent together at the SCNs, but she really embodies the notions of a learning health system and health system transformation, and she's going to talk to us today about that. So please join me in welcoming all of our panelists. And with that, Kristen, you're up.
here's all the slides. Perfect, okay. So first, I just want to thank the organizing committee for having me back to the University of Calgary. So second, I was fortunate to do my master's and PhD with Cy, and he truly was a leader within Canadian healthcare, and more importantly, really in all facets of his professional life, within orthopedics, within his research teams, within administration, and specifically the students that he had mentored. He always challenged me with those three questions. He'd always come into research meetings and say, Kristen, so what? What's your why, and what's gonna be your lasting impact within orthopedic care? So there's some people, when you meet them, you just want to emulate them. And I think they make everyone around them feel included, valued, and inspired. And I think Cy was that for a lot of us. Cy had this incredible ability to bring together these large-scale teams and really lead them very effectively. I'm sure we can all think of individuals, both within academics, outside of academics, that have differing leadership styles, and then some we want to mimic, and some certainly that we don't. I challenge us that that's the actual opportunity. So I want you to guess what percentage of leadership skills are actually learnable. So show of hands, what percentage do you guys think? So like 10%? 30%? Okay, 50%, good, more, okay, and 70%. Okay, so I'll get back to that at the end. So why should you invest in your leadership development in orthopedic care? What types of leaders are there, and how does this change within certain responsibilities or roles you have, or certain situations, and why is it imperative to be coached to lead a team? So where do management and leadership intersect? So all leaders manage, but only some managers actually lead. So has anyone read the book Start With Why by Simon Sinek, or read it or listened to his TED Talk? Yeah. So it's one of my favorite leadership quotes. So there's leaders, and then there are those who lead. Those who lead inspire us. We follow those who lead, not because we have to, but because we want to. So I've added just a QR code if anyone is interested in either the book or his TED Talk as well. So as a surgeon or a scientist, how do you develop your culture within your research lab or your operating room? And maybe more importantly, how do you develop the culture of who you are as a person? And for those of you who had the opportunity to meet and work with Cy, how did he develop that culture for you? So I'm a big sports fan. So Bill Belichick has a famous saying of do your job. So my personal coaching philosophy, my mentality has been always to make things as difficult as possible for players in practice. However bad we can make them, that's how I do it, or how I make them. So do your job means being prepared, working hard, paying attention to the details, and really putting the team first. And then in contrast, Peter Carroll's famous saying is, I'm in. So there's magic when organizations can inspire people to align their own passion, self-understanding, and desire for growth really with an organizational ambition. So his leadership style is really quite the opposite, and opposite of the traditional one. It's more humanistic and really based on developing and nurturing strong connections with his players. And both are very successful NFL coaches, but they have obviously very differing leadership styles. And these are some of the most well-known prominent leaders of their respective organizations or companies. So Steve Jobs, Mark Zuckerberg, Bill Gates, Oprah Winfrey. So I just want you to think to yourself, what qualities made these leaders exceptional? And really, what qualities did Cy have as an exceptional leader? Things like grit, emotional intelligence, kindness, vision, brilliance. So traditionally, scientific and surgical competence has really been defined by knowledge, technical ability, critical thinking, and analysis skills or data analysis. Well, little focus is really given to any other soft skills. And today, the non-technical abilities such as communication, leadership, really ultimately translate into better orthopedic care, experience, and patient outcomes. With an ongoing shift towards patient-centered care, scientists and clinicians really work more frequently in large-scale multidisciplinary teams as well. And upon the completion of an individual's academic training, many hold leadership positions, including roles as department heads, deans, principal investigators. However, in graduate school and medical school and even residency, It focuses really largely on knowledge, and very little training is actually focused on the soft skills or professional development. And along the path, there's really any training for other parts of the job, including running a business, motivating your team and employees, mentoring them, negotiating, leveraging their success, and really learning from their failures. So the presumption is these tasks can be accomplished, and really accomplished seamlessly as you transition through these roles. But fortunately, these skills can be developed and refined. So show of hands, have you ever been coached to lead a team? So a few hands, that's good, okay. And I'm sure there's several people in this room that currently have leadership roles. And a further show of hands, have you completed any formal leadership training? That's more than when I give this similar talk, it's more than I usually get, which is awesome. So what is leadership? It's establishing a clear vision and sharing that vision really with others so they'll follow willingly. It's providing information, knowledge, and methods really to realize that vision. And then it's coordinating and balancing conflicting interests of people and members on the team or the stakeholders involved in the group. And so why do we need to develop these skills in bone and joint health? And it really allows for exceptional quality of care and research, and within the clinic as well. It facilitates a supportive work environment for a multidisciplinary team. It allows for a more efficient use of resources. And lastly, it really shapes the local environment, and specifically SCI in influencing healthcare decisions. So leadership is a talent, and really everyone has some in differing amounts. And really the challenge and the opportunity is to develop your personal talent to its maximum potential within leadership. So it's not about meeting someone else's expectation of what it means to be a good leader. Oops, sorry. So there's many common leadership styles: coach, visionary, servant, transformational or transactional, you've probably heard about, laissez-faire, democratic. So I want you to think about which ones are most associated with surgeons as well as scientists. So people aren't really limited to using one leadership style, and you'll see a number of these really show up for both yourself as well as your leaders. So leadership training should begin in graduate and medical school and really continue through research or clinical practice. Formal programs can provide surgeons and researchers specifically with insight, experience, and skill sets. And these leadership skills are really used in every day and are particularly valuable when shifting roles or taking on new positions, whether it's in your home institution or within national organizations. And it's increasingly recognized that leadership skills are really a key requirement to being successful, really regardless of discipline, at all levels of experience or seniority too. Every day, clinicians and surgeons lead teams on wards, in the clinic, in the operating room, and research settings. But as reported by Barnes et al., most trainees and actually some surgeons don't even consider themselves as leaders. So really the non-technical soft skills should be valued and trained. So we want to empower coworkers really to create a vision by building consensus, developing teams, clarifying roles, and really earning loyalty within the group. And really effective leaders use communication really as a vehicle for their success. So that includes intentional listening, asking open-ended questions, and really creating a dialogue for your group. So innate talent plays an important role, but it really is insufficient on its own to produce an expert. So multiple theories that explore motor skill and acquisition in memory are relevant, but the development of competence and really leadership competence is by deliberate practice, and that's been especially influential. This is one of my other favorite books. Leaders today achieve really far more by inspiring and empowering their group or their people and trusting them to tap into their own talents and potential. And this approach really produces far better performance, and in fact, it's really a new, better way to lead. So leadership shows us that 70% of leadership skills are actually learnable, and that leadership competence is really reached through practice. So just like surgical and research skills, leaders are made and not born. So I just pose the question, how do you want to lead your either research team or clinical team? Even after 10 years, it's lovely to see the impact of this lectureship that's had on the academic community within Calgary and within globally as well. So when you're leading your team, I just encourage you to continue asking the 3 questions that Sai always asks me. So what, what's your why, and what's going to be your lasting impact within orthopedic care? Thank you again for the invitation. I'm honored.
Well, first of all, I'd like to Thank you to be able to present. This is a great honor for me to be here today. I'm going to try and talk about the evolution of orthopedics since I've been involved starting in 1983, so now 42 years. When I first met Cy, he was, as a medical student, a larger-than-life person wearing the surgical gown. He used to wear clogs, so he was almost as tall as Ryan, but I don't think so. And this is what I aspired to become. And he then became my teacher, my colleague. He was a patient of mine, and I was a patient of his. So I knew him intimately, at least parts of his knee. More importantly, he was a friend and a mentor, and I think the concept of mentorship that Kristen just talked about was crucial in his leadership skills. I really don't know how he did it, because he was able to mentor people from every walk of life under every circumstance, and he was very inspiring to all of those around him and very supportive all at the same time, despite a lot of difficulty that he rarely talked about unless he had a few drinks. So he inspired me to ask the right questions, understand the answers, and in particular, alternative explanations that you wouldn't have thought of. So I'm going to try and talk a little bit about the objective measures that I was taught as a resident 40 years ago, talk about subjective outcomes, and then use a couple of examples in my own practice and in my own research, and then summarize. So we need objective measures, and this is all we went on 40 years ago. A broken bone needs to be fixed. A bone-on-bone arthritic hip needs to be replaced. Very simple, very straightforward. Here's what I needed to learn, and here's the answer. If we look at a rotator cuff tear in the shoulder, clearly the size of the tear must mean more pain, more problems, and if you have a torn rotator cuff, we should fix it. Very objective, very straightforward. We would measure range of motion so that we knew how the impact on the knee was with respect to stiffness or otherwise. In the 80s and 90s, if you didn't use this instrument here to measure the translation of the knee joint, you couldn't publish a paper on ACL surgery anywhere in the world. So it was a requirement that we use these objective measures. And I can't imagine how a patient can distinguish between 1 millimeter of translation or another. But that's what we were forced to do. So I changed my tune when I met this person who had had ACL surgery about a year and a half before. And she arrived in our clinic in London, Ontario when I was doing my fellowship there, and she couldn't walk. Her knee moved from 20 to 70 degrees. Her entire life had come to an end the way she knew it, from being an active soccer player to now functioning like she was 90 years old. And she was never the same. The only thing we could do was literally cut out her cruciate ligaments just to be able to get her knee straight in a cast like this one. So that was very impactful for me. Second person was a 20-year-old guy who wanted to become a police officer. And he'd had what could be suggested as ill-advised surgical treatment on the front of his shoulder when in fact the problem was in the back. His shoulder was now sticking out the back and was fixed there, and he couldn't move it. And he looked at me with tears in his eyes and said, "But all I had was an unstable shoulder." So we know that objective outcomes are really important. We can't ignore these things. But I would suggest that subjective things are really what we need to know. How many people have had a survey lately, whether it's Uber, the restaurant you go to, the service that you had, but it's usually just one question. So you go to a restaurant, they want you to rate the restaurant. Well, is that the food? Is that the server? Is that the price? How good was the vehicle? How good was the driver? Did he or she take the right route? So these are very useful things to know, but it's how we ask the questions that is arguably more important and leads to more information. We've evolved in orthopedics starting in roughly 1976. People started looking at visual analog scales to measure pain, but prior to that, that was unheard of. And then there's a thing called the SANE score, where we ask people just to rate their problems on a scale of 0 to 100. And that's great because it gives you a number, but it doesn't tell you everything you need to know. Then clinicians, in their sometimes arrogance, but certainly based upon their clinical information and empiricism, develop questionnaires. But if you look at a group of questionnaires in the hip and you give them to the same patients, you get a different number. So what questionnaire do we use? And some of these are very famous. They're still used today. So I started out developing quality of life questionnaires that were patient-derived and patient-determined rather than clinician. So we've developed several of these over the years, but the most recent one was a hip outcome tool that utilized more than 400 patients from 4 different countries. And this allowed us to find out what was really important to young people with significant hip conditions and put it all together. One of the interesting things we found when we did this is we asked surgeons to rate the same things that the patients were rating. And it turns out surgeons rate them on a scale of 0 to 5 much higher than patients. In other words, surgeons don't look at things the same way as patients do. That might sound shocking to some of you, but very true. And it turns out that we can take these questionnaires, we can shorten them up so they're easier to use. We can use a longer one for research because we need more information, and a shorter one that we can use in clinical practice that can be used day to day. And it turns out these are very complementary and show the same thing. This is a slide I always show when I'm talking about the outcomes that I've developed. There's not one questionnaire in the world that asks people about the impact of sexual activity with respect to their hip problem, except for this questionnaire. It turns out it's very important if you're asking 33 questions, and it stays important if you're only asking 12. But what surgeon would be asking this question? It would be very challenging for most male surgeons asking younger female patients this very question in person. So I'm going to finish off. That's the biggest learning, I think, is understanding what patients really need to know and what we need to know about patients when we're measuring them. And more recently, I've learned this lesson. We tend to tell people what to do and how to do it, but really we should be getting them to adhere to what we're suggesting. And this requires a change in behavior and has to be agreed upon by the patient and ourselves. Turns out adherence to treatment has very significant characteristics. If you give a pill, that's a lot easier than getting them to do an extensive rehabilitation program, which is what we require of our patients in orthopedics. So these are big challenges. 40 years ago in Calgary, nobody was doing rotator cuff surgery. And 35 years ago, it was starting to become a very common problem. And we operated on people for pain, loss of function, weakness, etc. And we based that decision on failure of physiotherapy or a cortisone injection, and then we went ahead and repaired them. In the meantime, we developed this other quality of life questionnaire to measure how people were doing with their rotator cuff disease. And we used this to do a clinical trial. It turns out that when we tried to recruit patients for this clinical trial, we were quite successful. The surgery worked very well, and there was no difference between the different techniques we were using at 2 years. However, in the background, most of the people that were referred for us to do the trial actually didn't want surgery. Most of them hadn't had appropriate treatment. So a very insightful research assistant suggested maybe we should inform them, get them better treated, and that's what we did. We conducted a prospective cohort study where these people were followed year after year. And it turns out with very dedicated, adhered to rehabilitation programs, 75% of the patients got better, and this stayed First year, 2 years, 5 years, and 10 years, and we switched our way of thinking from thinking most people needed surgery, 75% anyway, to the opposite, 25%. The biggest predictor of success was our quality of life outcome measure that was patient-based. So it turns out that this diagram, which I use every week in our shoulder clinic, is that the damage in the cuff has nothing to do with the pain that the patient experiences. So in summary, orthopedics, I think, has evolved a lot over the past 40 years, from surgeons thinking what we needed to know and looking at objective things to understanding what is important to patients and then measuring that in a meaningful way. And now we understand outcomes from their perspective and what is truly important to them. So Cy inspired and directed, sometimes cajoled, and definitely mentored us. And I think he's driven us to believe in understanding what is most important for patients and behaving that way, encouraging people to behave that way and measuring outcomes that way. So thank you very much for your attention.
Welcome. Thank you so much. It's such an honor to be part of this event, and I'm so excited to share and talk about the legacy of Cy Frank. He was, as you know, a mentor. He was an innovator. He was a wonderful person. He did so many things, and it'd be really good if I changed my slides. Sorry, I thought you were doing that. Okay. Anyway, thank you and so much. He was just extraordinary in so many ways, and we all know that. So you've heard the whole mantra of you stand on the shoulders of giants, and I wanted to recognize all of the people who have contributed, well, actually only some, to my career, but these are my giants. And in the bottom are the people who recruited me back from the United States to Canada, and then of course, Cy and Tom, who's here in the audience, who inspired Stephen and I, my husband, to come to Calgary and start on this path. So thank you. So to reiterate, if what gets measured gets improved, then it's critical we measure clinical outcomes, patient-reported outcomes, and I'm going to add system performance. We have to do that if we're going to measure impact. This is where we started on this huge journey with Cy. And no, I'm not talking about all of this, but the mantra was, together we're better. And so to do research with sustainable impact, we embarked on this research journey. And it included transdisciplinarity, it included and applied multiple methods, and we generated evidence and worked with patients. So I'm just going to touch on a couple of these to highlight how did we measure impact and how did we assess value. Our research on the evidence-based integrated model of care to improve access and quality of care in joint replacement won a prestigious CIHR National Research Excellence Award. And we used the Alberta Health Quality Measurement Framework with these 6 dimensions of quality of care and their related key performance indicators to demonstrate improvements in patient function, quality of life, and access to care. And it resulted in efficiency gains of over 33,000 bed days over 3 years. And this sparked change in Alberta and beyond. So now to our Arthritis OA team grant, which many of you in the room were investigators. We all know knee surgery is quite successful. Nonetheless, 15 to 30% of patients report little or no improvement in pain and function, and some patients aren't very satisfied when they can't run marathons and when they can't kneel to pray after they've had their surgery. So in our best knee study, which was with Gillian Hawker as a co-PI, we aimed to identify and predict which patients are most likely to benefit from knee surgery. As it turns out, that's something we can do something about, is about setting expectations. So the key finding in Best Knee was that realistic patient expectations preoperatively are critical for good outcomes. And as it turns out, we can set those expectations. So we went on to develop a decision aid. And we did this partly because in Best Knee, we learned that 40% of our patients had never tried any single other evidence-based intervention that was non-surgical before going to a surgeon. And this is recommended by international guidelines. And at the same time, we kind of have these long wait lists for surgery. So we developed this novel and individualized decision aid, and it informs patients basically of what are their options and how does it align to their treatment decisions with their expectations. So we were in a really unique position because we could populate this decision aid with actual patient-reported outcomes and based on quality of life, and we could individualize based on their age, their sex, their body mass index or BMI, and their pre-surgical pain and function. And this was routinely collected in Alberta by ABJHI. So we tested this novel decision aid in randomized controlled trials and showed that it improved patient decision quality. And we've made it available this year, and up 500 Albertans have been using it already. So the patient voice. During this time, we founded the Patient and Community Engagement Research Program. Working with Nancy Marlette, we applied her learnings from participatory action research with seniors, wasn't even in health, and we won a patient engagement grant back in 2015. And Tracy Waslick joined as the Alberta Health Services system partner with AHS and the SCNs. So PACER's evolved now into a distance learning program as a certificate through UCalgary Continuing Education. And over 200 patients have graduated from this program to date. PACER trains people with lived experience through a series of 3 courses as well as a research project internship. And to my knowledge, this remains the only program of its type in the world today. And this is Jean Miller. She was one of our very first, I see Tracy smiling, graduates. And along with Sylvia Tier, she published their PACER research internship project on quality of care of OA. The right information, the right resources and support, and the right relationships while we're waiting for surgery. So from this work in OA, we learned the key ingredients for impact. And we applied our OA research experience to our UCAN Can-Do childhood arthritis precision health program, which Dr. Haniel Gabalawi already introduced. And the key ingredient number 1 is to have a measurement framework to measure the impact. So we are doing this, and we are intentionally measuring the impact of our research for socioeconomic impact through the CASH framework. So you should recognize this, and I won't go into the details for this. We also love our frameworks, and we have a You-Can-Do integrated measurement framework specifically for the socioeconomic impact and economic evaluation to inform clinical and health policy decision-making. So ingredient number 2 is transdisciplinary and global partnerships to maximize the impact. And that's our PI team from UCAN up there. And Can-Do started as a partnership with the Netherlands and Canada, as you heard earlier. And we have a transdisciplinary team. We bring biology, genetics, clinical, health economics, and patient research partners together to do this work. And the third ingredient is adapting our research practices to include co-design and co-creation of research with our patients. And this is our first youth JIA PACER cohort in 2021. And their research project was on transitions from youth to adulthood with a special emphasis on mental health and supports. They won the CIHR Institute for Health Services Policy Research Award for the top 10 articles when it was published. So these are our 3 ingredients, and you wonder, is it good soup? Well, what impacts have we had? Well, regarding health and socioeconomic impacts, we've generated for the first time a comprehensive data on socioeconomic impact of JIA with respect to quality of life, with respect to work impacts, and financial impacts for families. Families struggle. Almost half report mental, physical, and activity-related challenges. And at work, they regularly miss work. But even when they go to work, they report being impaired at work. And I don't mean from alcohol. So regarding impacts on decision-making and social impacts, we've shown that access to biologic treatments for Canadian children lags behind European and US countries. And a comprehensive policy review by our UCAN colleague, Claire LeBlanc, shows that there remains wide variability in access to these treatments. So we see disparities. In terms of advancing the science, current practice for JIA is what's called trial and error, and there's a step up to biologics when other treatments fail. In UCAN Can-Do, we created a novel taxonomy that integrates the biologic, the genomic, the clinical, and health economics to precision health and take advantage of something called this window of opportunity for targeted and early treatment to control inflammation and arrest disease. So it changes that trajectory and essentially stops JIA. So Bob, pictured here, he has the most severe subtype, and it's called systemic JIA. And with traditional treatments with the high-dose steroids, he basically was in a wheelchair in his early years of life. And then when they were able to treat him with IL inhibitors, which are some biologics, it changed the course of his life. He's under control now, and he's riding his motorcycle instead of the wheelchair. So we're about to launch pragmatic randomized controlled trials to test systemic JIA and our whole taxonomy and treatment paradigm for these kids. If successful, it will change the face of childhood arthritis, which is what we're all dreaming about. In our personalized medicine research roadmap, with many steps along the way, because there's always lots of steps, we're leveraging the UCAN data collection platform, the tools, and the infrastructure to continue to build, and I'm just going to mention a couple. Here, we're leading a whole program, a European rare disease program, in collaboration with Germany, Switzerland, Spain, Israel, and Belgium, along with our patient advocacy organization, Cassie and Friends. And we're co-creating a comprehensive value framework with our patient and parent partners to identify all the ways that arthritis impacts families. One Child, Every Child is a Canada First Research Excellence Fund, and it's a major transformational child research health initiative. I had the privilege of working with Susan Bensler and Francois Bernier and our whole wonderful team on this application under the leadership of Bill Galley. And we're grateful to have massive matching support from our community. We used the case example of systemic JIA from UCAN Can-Do to illustrate our precision medicine approach, focused on that early diagnosis and treatment based on the biology to change care. To quote Cy, naturally and justifiably, with greater investments like this one, he didn't say that, came increased return on investment. So, lo and behold, this is what we have. This is, in our application to One Child, Every Child, an integrated impact by design framework, which includes a cash framework, and it's focused on the return on investment of our research and the pathways to get to that impact. It includes co-designing with patients and families, an equity, diversity, and inclusiveness lens, an Indigenous parallel path with ways of knowing, ways of doing, and ways of being in ethical space, UNICEF outcome measures, and the Government of Canada science, technology, and innovation measures. I'm delighted that Catherine Graham is a key member of our One Child, Every Child Value and Impact team. She worked closely with Cy at Alberta Innovates, and you know her very well, Tim, and they created an international school for research and impact assessment based on the CASH framework. And so, to close, the legacy of Cy Frank lives on in so many ways, as you've heard. And soon after I arrived in Calgary, I will just share that I was working on this, Cy was working on this framework intensely, and it seemed endless. He'd come out of his office and sought impact on version after version. At the time, I had no idea what the significance of this report was, but I really do now. And thus, we continue our work in Cy's legacy, and we advance both the science and the practice and application of this. With so many thanks to our patients and our patient partners, and this has gone into Tracy's. Somebody's, oh, I'm going forward instead of backwards, but I do just want to take that second to go, thank you, because everything like this takes so many people and contributions, and these are our patient and parent research partners, and you can check this out at this QR code. So thank you so much.
Well, now you know what my slides are. I too want to echo my thanks to the organizing committee for allowing me to tell this story. It's hard to tell 15 years of work in 13 slides, but I'm going to give it a try. Cy's vision of the strategic clinical networks was as an enabler of a learning health system. And in our early days of design, we talked about an innovation pipeline to drive change and transformation in our ecosystem. And so I want to talk a little bit about that today. But before I do, I would really like to acknowledge my first medical dyad partner, my colleague, and my good friend, Dr. Tom Noseworthy. Could you stand, Tom? He needs no introduction in this audience, but Tom has contributed significantly to the health system in Canada and internationally, and he's done so in a variety of capacities. And Tom and Cy and I worked together tirelessly to see this vision come to life. And working with Tom and Cy has been and continues to be some of the greatest highlights of my career. So thank you, Tom, for being here today. So one of the things that I know everyone in this room knows about, Cy was really passionate about the Canadian health system and had this desire to make sure that it was sustainable. And he knew that we had to change the system if we were going to sustain it. And he was also very focused on the fact that Alberta's system, despite all the money that we've poured into it, was not performing at the level he felt it should. And so that sparked this idea of transformation of Alberta's healthcare system. And he had a very strong understanding of where we were. He felt we had the basic elements of a learning health system, and he spoke about them well before all the published literature that we see today. He really penned a learning health system before it was published. He felt that this learning health system, if we were able to create it, really could give us health gain, but also social and economic gain for all Albertans and Canadians. And he really felt the ingredients that we had were, we had this good population of 4.2 million people. We had actually started this journey of an integrated health system, and we had fabulous health partners. And so our mantra at the beginning was, how do we build the best performing health system in Canada? And this is where we started. We knew that the reality was this was a complex system. It was not integrated. Everyone was moving in different directions, and there was lots of barriers and traffic jams and dead ends in thinking about redesign. And the trick really was, how do we get everyone moving in the right direction? And Cy knew that if we could get everyone rowing in the same boat, in the same direction, we would be able to very efficiently use our limited and scarce resources to drive change. We could quickly deliver innovation into the system, and we could effectively translate ideas into outcome. And so in early 2008, Cy was very successful in getting the policymakers, the delivery system, and the academic leadership to start thinking about how this might happen. So he really was trying to pen a learning health system. And you've actually heard a little bit about, from some of the other talks, this whole how do you generate knowledge and how do you use knowledge to change behavior and how do you get better outcomes. But in essence, it really needs to start with the learning community. It has to be multi-stakeholder. It has to be interprofessional. It has to be grassroots. And Cy always talked about bottom up, not top down. I know some people don't like that term, but really it was how do we bring everyone together and bring passionate people together to solve the vexing problems that we have in the system. And if we were able to do this and emulate this, we could create a reusable infrastructure that any clinical area could apply, and we would be able to evolve people, process, and technology to create a culture in an organization of continuous learning. And Cy knew that there are a few ingredients that had to come together to make this happen. We had to have both academic and health system collaboration. We obviously need to know how to do quality improvement and implementation science with fidelity. You need highly efficient data systems because you won't be able to do it without that. And most importantly, you need rigorous evaluation. And you've heard this from everyone. If you don't measure it, you can't manage it. And so the SCNs were born through that thinking, and they were really focused on research and innovation to deliver health, social, and economic gain for Albertans. And the SCNs were these continuous learning communities, and the big key feature that Cy really pushed hard to get was this integrated research arm of each network. And the scientific offices were one of the unique features of Alberta's networks that no other network in the world had seen. And in fact, when we were reviewed by an external reviewer from Intermountain Health, they really called out that scientific engine within the networks being critical to our success. You all have heard that Cy often will take you for a glass of wine or a beer because he has an idea and he wants to talk to you about it. And I remember him penning this strategy on a napkin and saying, we can invest more money in the system, we can't afford it, so we got to find a way to eliminate the waste in the system, draw out get the gain from those waste, design projects that will eliminate that, and then use those gains to reinvest into both healthcare and continuous research. And if we did this well, we would create a sustainable health system. And it was with that when we started the SCNs, each SCN, actually, this was one of the 3 things that each network was charged to be able to do, is to have a project that would eliminate waste or stop doing something that wasn't adding value, because if we could do this, then we could measurably change the system. And so it was a major building block of the teams that were constructed when the networks were formed. But networks can't just do that. They have to have a whole bunch of other skills in order for that learning health system to be accomplished and achieved. And so there were many key elements that we worked hard to introduce to the teams that work the networks: advanced analytics and population-based insights. Obviously, patient, provider, and clinical operations co-design. We needed to synthesize the evidence and understand what was already out there. You can't get to scale if you don't have implementation science capabilities and obviously measurement and feedback. And so the provincial model that was penned in the early days of our work is this. And Cy was, although he was a specialist, he totally understood the health system. And he said, the first thing we have to do is put patients at the center of this work. Because if we invest in primary care and we have every patient attached to primary care, then we know we're going to have a better integrated system. And obviously, at the peak of the networks, we had 16 SCNs and we had 3 or 5 that had provincial programs that had network capability embedded. And one of those was the Primary Care Integration Network. And so the final ingredient that I wanted to chat about was the innovation pipeline. And the SCNs used the innovation pipeline. This was that picture that we really actually turned into a systematic way of enabling rapid and rigorous evaluation and implementation. And this diagram really illustrates how we standardized the approach to introduce innovation, fail fast if it wasn't working, and if it was showing promise, how do we get it from a pilot project? How do we test it in Alberta? And how do we then spread and scale it so that the improvement becomes the norm for clinical delivery? And this framework was used throughout the generation of the SCNs. The scientific offices played a critical role in what I would say is the front end of the pipeline. And then when Cy went to Alberta Innovates, he introduced with Dr. Catherine Todd the Partnership for Research in the Health System, which was a fund to help us advance innovation into the Alberta context. And because that was so successful, and Tim from Alberta Innovates is here and was a key partner there, we were able to convince the Alberta government to invest in the health implementation and innovation strategy, which would take promising practices to scale. And there are many examples of how that happened. So I want to finish off by saying Cy felt that if we created a model and we had the right tools, we could have a return on investment and an impact in Alberta. And I credit Dr. Chris Eagle, who sat Tom and Cy and I in his office on the 14th floor in Edmonton and said, you've got to get juice out of this lemon in 3 years. This is a big investment. And if you can't do it, you're done. And so we did an early ROI, and it was promising. And then when Dr. Verna Yu became our CEO, she says, yeah, let's make sure that this sticks. And so in 2019, for every $1 invested in the networks, we returned $1.50 back to the Alberta healthcare system. And from an academic perspective, when you think about drawing money into the province to be able to do research, in our scientific office report over the years from 2020 to 2022, we brought in over $103 million in research funding to Alberta, and 70 million of that was from outside of Alberta. So we were generating economic and social value beyond just health value. And so just final note was the lessons learned in the evolution of the SCNs. I don't have to tell you what's happening in Alberta. You probably know better than I. But nationally, Cy's fingerprints are all over many other provinces in this country. And there is an enormous shift. Oh, sorry. Oh, I'm doing what? I got to go backwards. I did what Deborah did. During the tenure of our time, 8 Canadian provinces reached out to us with this idea of wanting to understand our integrated system and our networks. We know there's been actual networks implemented in several provinces in this country, and last year at the Casper conference, the SCNs were recognized as nationally as one of the most integrated learning health systems in Canada. And so I think SCI's legacy has really gone well beyond Alberta's borders. Thank you.
So we're going to get the chairs set up. If you haven't already scanned your QR code to ask your questions, please do. We've got about 25 minutes for questions. And we all know that after that, we saw the next slide that Verna Yu is here, and she's going to be speaking as well. So that was a really nice, 4 nice talks that again illustrated Cy Frank's leadership. We heard about mentorship, the importance of leadership. We heard about patient-reported outcome measures, helping patients make the right decisions, the importance of partnership and co-design, and then we heard Tracy talking about learning health systems, something that Cy, Tom, and Tracy really worked on. So we do have one question so far for Deborah and for Nick. So the provincial government appears focused more on access and less on the other dimensions of healthcare quality. How can we change that?
Well, I think access actually is the most important thing right now. So we're not going to change the outcomes unless we get the patients in, and we have to focus on what is the biggest problem with respect to access. The focus of the Alberta government is on surgical care, and the truth is that's such a small percentage of the overall care that is actually required, even within orthopedic surgery. So the other part of answer to that would be, how do we know what we need to do, and how are we going to measure outcomes if we don't know what the problem is in the first place? And we really don't know what the problem is in terms of access, how many people are out there, what they really need. So I think we have to start there, as Cy has told us to, and then we can move forward and look at quality and everything else that goes along with it.
So that's a great question, wherever it came from. There are multiple dimensions to quality of care, and I think we've all illustrated that in different ways. Yes, I think access is absolutely critical because there's a lot of variability in access. So we need to have an equity lens in mind because we have a large province with a lot of barriers and challenges for various people to access care. But there's other things we have to look at as well. And how do you actually approach that? One, I'm sorry, I'm going to say it again, but we have to be able to measure it. So to me, one of the keys is working with our patients, as we were saying, and really make sure we understand what's important to them in the measurement, and being able to bring that data forward. And I don't just mean numbers. Bring the information forward, bring the stories forward, because it can be qualitative or verbally communicated, and this is where the advocacy side comes in as well, to make sure we're getting those messages to our governments and the people who can make those decisions. So this is why, for me, I'm so passionate about making sure we work with the patients, with the people, and I'm also going to say the taxpayers. And even if you're not actually using the healthcare system right this moment, pretty much, I can guarantee everybody in this room will be accessing the healthcare system. And what I'd really like to do is say we don't have a system. And what I think we have to think about is it much more broadly, because it's not just services that are delivered in bricks and mortars, but a lot of different options for supporting patients to feel well, not just health, but health and wellness. So we need to look at a wide range of things we can do to improve patients' health and wellness, not just the actual delivery of health care.
Dr. Barton, I have a three-part question for you.
3 parts, oh my goodness.
So one person, I'm going to sort of blend them together, and I can prompt you if you've. So it's all about leadership and trainees, acknowledging that aspects of leadership can be learned. What are your thoughts about the skills a trainee might have that often translate into becoming a good leader? What piece of advice would you give a surgeon looking to become a better leader? And then what should we be providing to trainees? What should the surgical training programs be actually providing to build those skills?
Yeah, so maybe I'll answer the first question, or the last question first, if that's okay. So when I was actually at the University of Calgary, we developed the Leaders in Medicine program, executive coaching program, so with an executive coach. And now we've actually scaled it to the Canadian Orthopedic Association. So we developed basically an emerging leaders program within the medical school, initially at the University of Calgary at the time, it was the MD, PhD, MD, MSc program for leadership coaching. So basically they went on to have one-on-one coaching with a leadership coach, and then we did small group sessions throughout the course of the year. So while I was through, I guess, in the program for the 7 years while I was here, we had over 35 MD, PhD, MD, MSc students go through the program. And then now with the Canadian Orthopedic Association, we've developed basically a cohort every year for emerging leaders, so the early surgeons within the first 5 to 10 years of practice, to be able to develop those leadership skills with a leadership coach. The second question was...
Well, what attributes would a person coming in have that would make them more likely to be a leader, and what advice would you have if they wanted to become a better leader for that?
I think it all ties down. There's, as I mentioned before, there's so many different types of leaders and leadership, and I think really building upon understanding people's emotional intelligence, understanding how they communicate, are like some of the two biggest things that we can do just as like people within any teams or groups that we work with. So I think those are the two key things would be emotional intelligence and communication skills initially. The first question was?
So you've already addressed the first one. The second one was just advice you'd give a young surgeon that wanted to become
I would say the biggest thing is get involved. Get involved in leadership opportunities to be able to learn leadership skills, but to get involved with a leadership coach or a leadership training within the curriculum. So, over the course of the University of Calgary program, they've instituted the program through the MD PhD program. So if you're involved in that, I'd highly encourage you to get involved.
Okay, so here's a challenging question. Tracy, I'll let you take this one first, but happy for others to weigh in. So we've got a lot of health system change going on from a system perspective, and there will be some churn that continues for a bit. From your perspective, what do we need to see from within the system? What types of structures and characteristics within the system do we need to see to continue the attributes that Cy Frank wanted there to be in the system? To continue the Cy Frankism was how it read specifically.
I guess I don't work so I can be pretty honest, right? No, I'm just teasing. What I would think Cy would say, and what I think is the churn has caused a dearth of strong visionary leadership. I think there's a lot of people working really hard to manage the system, to respond to the threats, the obstacles. But I think that in order for us, structure is one thing, but structure isn't sufficient. You need really strong visionary leadership to be bold and to really take the strategies and the concepts and make them real. And when I think about how lucky I was in my career to have strong leaders who saw Cy's vision and helped make it happen. And, Chris Eagle was one of those. There were deputy ministers who felt this is the place to go. Verna was a staunch supporter and took a lot of arrows for us to allow us to keep moving forward. And leadership is what you need to sustain and change structure so that you can enhance the learning health system. And the only other thing I want to say is, and it's around primary care, and investing in primary care is a key building block. We will not have an integrated system if we do not have a robust primary care system that we're building around. And so that structurally needs to continue. I think it is here, but I think we need to build on it. And you want other people to respond.
Sure, Nick, I wonder if you have a comment. There's another comment or question that sort of melds into this, which is how do we make sure we continue to do what we know works best in the current environment? I think it sort of builds on your question of it's not just about surgery.
Yeah.
It's
Well, I would just say for the first part question that many of us here do research. We do research because we want to answer questions. We have so many problems in the healthcare system, but we're afraid to research them. We're afraid to try new things and fail. So we continue with the same thing over and over again, put more money into it, and continue to fail. So I don't know why we aren't investing. It's the largest corporation in Alberta, as I can consider, is the healthcare system. Most corporations have a research development department and a significant funding to go along with that, and there's many other international jurisdictions that require that in order to innovate or change. And that's the only way we can change. People aren't going to change because they're told to change. They're going to change because the evidence demonstrates it's necessary. So I think we're afraid to change. We don't want to change. And what's the best way to do that is to try something out and fail. As Tracy said, you try a pilot project, you fail, you move on. If it works, you continue with it. And then you get leaders, you get people who are innovators, people who are visionaries to drive that change and inspire people to do so, which is really what SCI was all about. We're afraid to measure things. We're afraid to use the data. Why don't we use this data? Why is it so hard for somebody like me who wants to do research into the population in Alberta to go through all these hoops to use data, by the way, that everybody in this room is paid for because we're all taxpayers? Why shouldn't we be able to use that to benefit Albertans? And one of his dreams was to use this as a repository to generate income from other jurisdictions because we had this incredible, valuable data set that nobody else had on 4 to 5 million people. Anyway, I could go on for hours. I won't.
Thanks, Nick. Deborah, I'll give you one quick response, and then Kristen, coming to you for a question.
Yeah, I just wanted to add to that. I absolutely agree. We really need to use our data, and I guess to be brave enough, maybe we have to call it brave enough, to actually look at it and act on it. I used to work in industry, and I got to tell you, it was fail fast, because the last thing you want to do is keep investing in things that we know don't work. And that certainly is something that has been promoted very much by the Institutes for Health Improvement internationally. The encouragement is to fail fast. And that's a learning, and then move on and do it better. So that I would really encourage very much.
Dr. Barton, so you've had some experience in other healthcare systems outside of Alberta. What reflections on Alberta's system do you have? What do you see as advantageous in Alberta? And there are other ideas you think we should be bringing back here?
Such a tough question. So I'm currently in the private healthcare, private academic system, and I feel like the biggest thing is like you're in the States, you're so driven by money. You're so driven by, I guess, the resources that you have available, and bringing it back, I'd say, into Canada is we don't have like I feel like access to care sure is quicker, but I mean I feel like the things that you can bring back to the Canada is like we don't have the working groups like you do here within Alberta, which is a fabulous system. We don't have the SCNs. I think there's a lot of, and I know Cy talked about it ages ago, but we have more silos within the American system, and within Alberta you have the SCNs. You have the more the framework, I guess, that would be involved than that at least I've seen within some of the healthcare systems that have worked in the States.
Thanks. So Tracy, coming back to you, so Cy was all about generating the best evidence, what works. How do we get it into the healthcare system? Testing it in your innovation pipeline, testing it and then spreading and scaling it. This question is, we all know what happened to the SCNs. So if you could do it again, or you're talking to those 5 other provinces that are currently implementing the networks, what would you suggest they do differently?
Well, the last network we launched was the primary care integration network, and it should have been the first network that we launched. So in my conversations with other provinces, what I have said to them is, if you can start in primary care and put them at the center, I like your chances of then connecting specialty care around and supporting primary care. So that would be one piece of advice that I would offer the other provinces. The other failure, I wouldn't call it a failure, but we had our highs and lows, was there's 2 groups of people in the system. There was us trying to drive and design the healthcare system for the new user, and then there's people that have to run and manage the system. And while the people who run and manage the system are very bright, intelligent, capable, innovative people, they don't have the time and attention to focus on the future. And even though I think they want to. So my advice would be making sure that operators are in the circle of being part of that co-design, and finding ways, given the time pressures that they have, for their inputs to be realized in some small way. Because if you lose the people who run the system, then you create that dynamic tension of us and them. And Cy was always, his words to me were, Tracy, it's like if you don't get invited to the dinner table, you're the after-fact invitee to the dinner table. You always feel like the outsider, that was the last guy got invited to dinner. So make sure that operations feels like they were the first invitees to the dinner table. And that is a tough thing to do, but it's critically important if you want to all be rowing in the same direction.
Thanks. So I sense this question was for Dr. Barton, but actually I think everybody could weigh in on this. We've got some trainees in the room. And I think trainees are always, I love the enthusiasm, and they don't know why we can't do things. But when there's sort of a situation where there's not a lot of resources, maybe there's not networks, but if you're a trainee, how do you advise the trainees to get started with, to use their words, moving the needle in medicine, moving the needle in our systems from a trainee's perspective? How do you provide them some hope that what they should be doing? They want to have an impact.
You want me to start? I would say just get involved as soon as you can within teams and groups, like through the McCaig Institute, through the medical school. I think you learn those skills, and then you're in positions to be able to make, or to have opportunities to make the change within the organization. So you have to first get involved, but really start and have the foundation and the groundwork to be able to work your way up, I guess. So I guess as a trainee, just get involved in the clubs, the after curricular groups that like within the medical school and within the graduate programs, I guess.
Anyone else? Yes, Deborah?
Yeah, absolutely. And there's quite a few sciisms around this. OA team grant. Most of you were in that team. Everybody's going to be in the room together, and we're all going to listen to the basic science talks and learn about it and appreciate it. And the basic scientists are going to listen to the health economists. And that's how you create a team, and you learn how to work together. I think that's fundamental. So for trainees, my advice would be get involved with the team. Don't just hang out with the same people. Go and explore, learn other disciplines, go to a wacky talk that you have no idea what they're talking about, because it might inspire an idea, and it will teach you or inspire you to think differently. I mean, one of the things about our childhood arthritis is thanks to Hani. We had the rheumatologists in the Netherlands and the rheumatologists in Canada. And it's every single rheumatology pediatric center in Canada and in the Netherlands. Well, guess what? They do things differently in the Netherlands. Well, we're learning from them, and they're learning from us. And that just happened because we're in that multidisciplinary, well, actually transdisciplinary and global partnership, and we just keep learning from each other. That's what I think trainees will best gain from, right? And keeping an open mind and having that sense of inquiry and not accepting we always do it this way. You know, well, why is the question? Why? Why do you do it that way?
Any other sage advice for the trainees before we move to our last question?
Very quickly, if I'm giving a teaching session, I demand that people ask questions. Because you know half the people in the audience don't know whether you've delivered the message very well, or maybe they don't understand, and if they don't ask questions, they're not going to learn. And when you ask questions that are based upon your patient care, then you're really going to get passionate about looking for answers.
Thanks. So we often tend to focus on the save, the great save in the healthcare system. We don't always focus on preventative medicine. So this question gets at that. So preventative medicine can have significant return on investment for health systems. Why aren't we investing in it? How can we be more proactive in healthcare and medicine? A couple of quick responses.
Well, the political cycle trumps the prevention return on investment cycle for one. So that's one thing that we've struggled with. We actually try in the population and public health group, from a research perspective, it took about 10 years, but they got a PRIUS grant to look at social determinants of health, using acute care as the vehicle for that measurement. And it took a long time for them to construct a project that the funder could see the value in, that wasn't like a 20-year runway. And they had designed it in a way where we were going to actually get some outputs within a 3 to 4 year cycle. And so part of this, how do we invest, is, I think, as a health research community, we have to kind of design projects in a way where even if the runway for outcome delivery is longitudinal, using the CAS framework, we did that in a couple of projects to inch our way along that trajectory is really critically important. And I don't think we've done enough of that in our design and in our thinking about it.
One last brief response. Okay, Deborah.
Well, as a health economist, it's actually really hard to get people to think about long term, and especially in this world of instant everything, it's really hard to think longer. So I think what we need is discipline as a society, actually, and behavioral change, which is very difficult to do. But I think we have to stop this short-term cycle because we just keep going in a cycle. So really being committed to behavioral change, the Norwegians did it with their oil. They invested in the year 100 fund with their profits for the benefit. I lived in Sweden for 4 years. Long-term investments. And data is required on every person in Sweden for the social evaluation to look long-term where to invest.
Who knew we'd have a Nordic finish? Big thanks to our 4 panelists. And we'll get Dr. Barnaby back up here. The art is looking good at the back.
All right, so thank you to everybody. Thanks, Braden, for leading that. Our final keynote presenter for today is Dr. Verna Yu. We're all fans. Verna, thank you for all the work you did. She is currently the provost and Vice President Academic at the University of Alberta and a Professor of Pediatrics. She has led such major innovations in our healthcare system, including the implementation of Connect Care, which I'm getting around to liking a little bit more, and also, of course, leading the tremendous response to COVID-19. So please give a warm welcome to Dr. Yu.
All right, well, thank you very much. It was a real honor to present, and on behalf of Cy Frank's legacy, I had the pleasure of getting to know Cy when I first joined AHS in 2012. And that was at that time, I think, Tom, it was the first launch of the SCNs at that time, and this was up in Edmonton at the University of Alberta, and there was so much excitement about what the possibility was around this new innovation. And over the years, I got to know Cy. We've already heard such incredible things about Cy, but just to say that the impact of Cy's legacy is really around, oh, sorry, okay, all right. You have to adjust for my height. Thank you very much for that. Is really about, how he's really been able to unleash innovation within healthcare. And, Cy's vision and parting words to the Naylor Innovation Report was that Canada should aim to build healthcare systems that were living laboratories, drawing patients and clinicians together in partnership with researchers, entrepreneurs, and innovators from all sectors and disciplines. And Cy was relentless in his pursuit of improving the healthcare system, and we all know that. But not only was he relentless in his pursuit, he was an innovator, he was a clinician researcher, probably one of the first ones, outstanding teacher, a generous colleague, and a wonderful friend. And I think we all continue to miss him to this day, but are very grateful for his legacy, which is why it's such an honor to be presenting today. And I think in a way, when I came up with the title about Prescription Without Sustainable Action, Canada's Healthcare Paradox, when I was actually doing the talk, I was kind of thinking, oh my goodness, I better do a good talk because that's quite a title. So I hope I am able to deliver. Just want to acknowledge a land acknowledgement that in Alberta we're located on treaties 4, 6, 7, 8, and 10, as well as meeting place for Métis. We respect the histories, the languages, the cultures, the knowledge systems of all First Peoples of Canada, and I'm very grateful to be a settler on this land. The picture there is a picture of the Sweetgrass Bear by Stuart Steinhauer, which is actually on the University of Alberta campus, as part of the university's efforts to work towards respectful, meaningful reconciliation with Indigenous peoples. And it reminds us all that we are all treaty people. She's a symbol of our relationship, and on the side of the bear is an inscription that reads, "We are all related." And engraved along with that are Sweetgrass teachings of humility, kindness, sharing, honesty, and determination. So the objectives of the talk is to do the following. First of all, I think we've heard a lot already about the current challenges, and I'm going to just do a brief overview about that, and a lot of it is obvious to everyone, I would say. Just a few slides around why we have not been successful to date, and again, I think a lot of it is obvious. The prescription of a strong, sustainable learning healthcare system, I think Tracy's already spoken to that to a certain extent, and then discuss that what we can do together to ensure that our healthcare system delivers on what it needs. And already there's a previous quote by Peter Drucker, but I thought this quote is very appropriate, especially in Alberta, that the greatest danger in times of turbulence is actually not the turbulence, it is to act with yesterday's logic. So Canadians actually know exactly what is important to them, and this is the latest polling data from Ipsos Canada, courtesy of my college, who leads Ipsos Canada, and it shows the most important issue for Canadians is healthcare and housing. And what's interesting in this is that when you compare to Alberta, note that economy is number one at 38%, followed by housing at 34%, and healthcare, in fact, comes in third at 29%. And again, this is data that's come out in July of this year. we know how fragmented the healthcare system is. This is not specific to Alberta per se, but is actually fragmented across the country in various degrees. There's a lot of dissonance with primary care. We heard about access issues already, and really the inability to provide the health and wellness care that is needed. Everyone knows about the aging tsunami, but some interesting statistics is that there are more Canadians now aged 65 plus than there are children aged 0 to 14. And projections show that the 85 plus population is going to triple by 2046. Coming out of the pandemic, we know there's been a huge backlog of chronic conditions, increased aging in our society, and we just can't seem to play catch up despite the fact that we've been doing more in the recent years. And we've already heard about wait times being particularly challenging. And even though we did more surgeries in 2024 in Canada, this has not kept up with the demand and the population growth. Talk a little bit here about sustainability of the system, and its sustainability not only in terms of costs, but if you look at the cost for healthcare right now, it accounts for about 12.4% of Canada's GDP. And it's rising about 6% per year, both within the public system as well as the private system. And we know that in Canada, about 30% of the healthcare costs are in fact private. Workload and exhaustion, I don't think I need to say much to this group here, but it's upwards about 70 to 80% of people who work in healthcare are experiencing these types of burnout symptoms. And then politicization of health and healthcare. It's been obviously interesting to watch, interesting to experience. There was a very interesting study that did a survey of physicians in the US about politicization and how much they experienced the intrusion of politics during COVID. And over 91% of physicians experienced intrusion. And what did that result in? That resulted in increased risk of burnout. It resulted in compromised integrity, moral distress. And what was very important was that not only was there higher levels of frustration and resentment, but less compassion and empathy in their practice. Health inequities were further entrenched, and again, this is, I don't think I have to say much to say that COVID-19 really further reinforced the pre-existing inequities amongst those who have low socioeconomic status, those who are migrants and refugees, ethnic groups, Indigenous communities, and health inequities are obviously more pronounced. This is a study that was, survey that was done by Abacus Data in April of 2024. And Canadians actually know that we are challenged in healthcare. In fact, they understand that we actually have shortages in healthcare workforce. They know that we have problems with wait times. They know we have an aging population and that is rapidly growing. So it really does show in this survey data the mounting apprehensiveness amongst Canadians about the healthcare system, and that it really is a matter that can no longer be overlooked. There have been numerous reports about healthcare in Canada. I just bring up the Naylor Healthcare Innovation Report, which is where the strategic clinical networks were mentioned. But to say that the problems that we've experienced in Canada have been here for decades is really an understatement, and we just can't seem to move. We remain siloed, we can't coordinate across jurisdictions, can't scale and spread best practices, we can't think beyond the immediate needs, we're very short-term driven, and we don't have any accountability. Who's accountable ultimately for improving quality of care? So why has there been no progress? Well, first of all, the politics and policies is an issue. The political cycle for Canada is an issue in terms that it is a 4-year cycle, and it reinforces that short-term thinking. I think, Deb, you had mentioned the issue about we just can't get that long-term vision. And why is that? Because every time we get a new election, government has 2 years to do anything. They tend to do most of their bold policy changes in the 2 years, and if they last the next 2 years, they're actually trying to spend money at that time to buy the vote so that they can get reelected. And so there's very, very short-term thinking. I can tell you that we sold Connect Care to government based on a 10-year vision. And essentially we said to government, if you don't provide us with a system that enables us to make informed healthcare decisions, the healthcare system will not be sustainable going forward. And so very grateful that all the moons aligned and we were able to get Connect Care. The lack of, I think, clarity between the federal government and the provincial government is another jurisdictional challenge for Canadian healthcare. The feds think they have a lot of say in healthcare in Canada, but the reality is when they provide healthcare transfer funds, it only accounts for less than 20% of what the province spends on healthcare. So no wonder the province feels that healthcare is within their jurisdiction and makes all the decisions accordingly. There are very, very few accountable metrics that the federal government puts on their transfer payments. Only most recently have they actually put some ties there, but even then, how they actually are able to measure what is deemed as successful is still going to be a challenge. And because of that lack of clarity, there's a lack of accountability. And I don't only mean as it relates to politics, I'm talking about lack of accountability at all different levels, including Canadians. You know, where in our system do we actually include Canadians at the forefront to say that you actually have some accountability in how you use the healthcare system, how you yourself stay healthy? And it really is trying to bring that dialogue to the forefront so that we can actually get that grassroots driven agenda. And then the last one I talk is about political arrogance. One of the things that I always ask people is, would you ever want someone who is a non-finance person to run a bank? And if the answer is no, then why do we do that in running healthcare systems? It is a real challenge when we have people who run healthcare systems, probably one of the most complex systems that we will ever encounter, who actually have no experience in understanding what the needs are, not only of the users of the system, but the people who provide the system. So along with why there's been no progress, well, obviously the structures and the systems, and again, the fragmentation really results in multiple organizations, multiple conflicting goals. Everybody wants a piece of a pie, so they're fighting for resources. There's lack of coordination and separate information systems that don't speak to each other. Again, we're lucky in Alberta that we've got NetCare and Connect Care. But very importantly, what's foundational to all of this is that we really don't have an integrated, interoperable, and standardized health data that really leads us to have an ability to benchmark and share and compare and do some common metrics. And that leads to the lack of a common agenda and lack of oversight. And really, you know, when we think about some of our antiquated funding systems, I still don't understand why we have a fee-for-service model which only rewards volume and no accountability in any perspective. How does that make sense for a publicly funded system? And then finally, the lack of informed leadership, as I said earlier, that obviously is very challenging. Why has there been no progress? Well, there continues to be workforce challenges. And, you know, very interestingly, you know, one of the predictions by a person who I met, Jim Buchan, who works for a health foundation in the UK, says, you know, the workforce that we're going to have now is going to be the workforce in 10 years. Well, can you imagine in 10 years with all the changes that are happening? If that is the setting, then we need to make sure that we change with the advances in technology, with advances of AI, with advances of different care models. It really is going to be on all of us to make sure that the change that we do, even though change is hard, that we really keep up with what is happening, otherwise we'll be left behind. You know, the models of care, we are still very medical-centric in many respects, and it's amazing that despite team-based care being present for almost 60 years, that we still continue to have challenges in understanding the benefits from what a strong team culture brings. Not only does it bring higher rates of quality of care, there's better satisfaction rates from both the user as well as the employee, better outcomes in terms of clinical outcomes, as well as lower cost to the healthcare system. And then the shortage. I don't have to mention the shortage issue that leads to further burnout because there's too much work for everyone, but the total number of job vacancies in Canada for healthcare workers is about 900,000. It's close to 1 million people. The highest number of most vacancies are for LPNs, RNs, those who work in psychiatric facilities. And the WHO, who predicts that by 2030, we are going to be needing an additional 9 million nurses across the globe. And then workforce modernization is really important because, as I mentioned, the scopes of practice is going to change as we get advances in technology and AI. And then there's innovation stagnation. There really has been, again, little progress over the past 30 plus years. Again, at the Naylor report did a really good summary of that. And the Naylor report, since it was written on 2015, has really resulted in no advances at all. In fact, when it was actually published, there was no movement on it or recognition of it, which is unfortunate because it was actually a really good report. Again, I don't want to repeat the accountability void, but the delays in technological advances for improving patient care is something that's coming faster than we ever believe. And if our system stays stagnant, then you can only imagine that we're not going to be able to keep up, definitely for the public demand. And there are multiple missed economic opportunities. I think there's already some mention around that. But when you think about Canada's medical device and pharmaceutical sector, that's really stagnant at about 2% of the global market. And that partly is because the innovators actually have no access to the real-world data to validate products. So if we contrast this to, for example, a country like Israel, which has a national health database, it is a magnet for health spending on clinical trials that exceeds about $150 billion. While in Canada, though, our share of clinical trials has dropped by 50% over the last 15 years. And so this is not only a financial issue for the country, it is a care issue because that means that our Canadians are actually not accessing the newest therapeutics and drugs. So what is it that Canadians want from their healthcare system? Well, we like to believe that the right to healthcare is a fundamental human right, and I've always been very proud of saying that. When I did my training in the States, I would always say that to my American colleagues. But just to note that there isn't any explicit right to healthcare in the Canadian Constitution. After saying that, though, the Supreme Court of Canada has affirmed that the Canadian Charter of Rights and Freedoms can apply to the provision of publicly funded healthcare, which in essence then can be translated into it being a basic human right. So my question is that really at the end of the day, this is a system-wide responsibility that all of us, not only those within the healthcare system, has to take accountability for. It is about ensuring that we've got health in all policies. I always used to say that every single ministry in government is actually a health ministry because there are always impacts, whether it be education, whether it be housing or seniors, whether it be in child social services. At the end of the day, almost everything impacts on healthcare. And it really is about making sure that we focus on health and wellness. There was always a question around prevention. But just to say that it can happen. In fact, what was interesting is that when we looked at New Zealand, when they redid their strategy in 2019, they focused their national budget and strategy into a well-being budget and strategy. And they moved away from their economic goal from increasing their GDP to actually improving the welfare of New Zealand citizens. So there are examples of countries where they really have taken that bold approach of really harnessing the energy of everybody that's actually within New Zealand to actually have a collective agreement on what it is about co-creating shared values. I've always been really proud of Alberta Health Services and how we landed with our vision, because I actually believe this is a vision for healthcare in Canada. It is about being healthy, about moving away from illness. It is about communities and community centricity, community-centric care, and it is about doing it together. And the vision was then complemented by our values of compassion, accountability, respect, excellence, and safety. And when we actually landed on our vision, we actually had a vote in the organization, and more than 13,000 people voted for the vision, because at the end of the day, it is the vision of everyone who's actually within the organization. So what is the prescription for the healthcare? And again, Tracy kind of beat me to it, but it really is about an integrated learning healthcare system. This is a presentation that I presented back in 2018-19, and it is about a paradigm shift of where we need to proceed. This is about moving forward onto an illness focus to a wellness focus. It is about going from a single provider care system to a team-based care model. It is from being a physician-centric system to a patient-family-focused system, and then moving away from a hospital acute care to that of a community care. And in fact, we actually had a 10-year vision in 2020 to continue with the paradigm shift and further embed what we knew was going to be key to a sustainable, high-quality healthcare system. And you can see the 10-year journey at the end of that was really an integrated patient, family, and community-centered care. And you notice in the middle was the enhanced integration of primary care. Tracy's comment of where primary care needs to be foundational to any successful healthcare system is the key to all of, to any system that we see has been successful globally. And so, you know, I mean, we know what integrated care is, but I really like this model because I think, or this definition, because I think when we think about integrated learning healthcare systems, we think about it from the provider perspective, and we need to switch that and think about it from the patient perspective. And which is why I like this definition, because it is from the patient perspective. It is about my care. It's planned with people who work together to understand me and my care. It puts me in control, coordinate and deliver services to achieve my best outcomes. I love that vision, and I love that vision of that integrated care, which is really then centered around the individual. Now, obviously, it needs to include aspects of the system and aspects of the finances, but really, that itself is probably the most meaningful definition I've seen of integrated care. And Tracy's already gone through sort of the components of integrated care about defined population groups. You've got to have the coordination, shared outcomes framework. You've got to have a remuneration, incentivized system that actually can lead everybody to the contributions. You've got to have the data. You've got to have the systems in place, the evaluation processes, and really the ability for everyone to feel involved and for the patients really to take ownership of their care. So why do we want an integrated learning healthcare system? And again, I think some of the previous conversations have already shared with you that this is about better quality of care, it's about better health outcomes. Ultimately, isn't that what everyone wants? It's about improved efficiencies, patient satisfaction, and provider satisfaction. Is about improved transitions of care, reduces the likelihood of errors, duplications, unnecessary interventions, and improved sustainability of the system. There was a little bit of conversation about how we used to be the most expensive healthcare system in Canada. And in 2018, we actually were that. This is the National Health Expenditure Database from CIHI from 2022. And in 2022, what was really rewarding for me to see was how Alberta at that point was no longer number one. We might be number one now, but we weren't number one in 2022. And as you can see, we were ranked now number 6th amongst the provinces. And what was really rewarding was that we were leading the pack in terms of bending the cost curve downwards, which took a lot of effort of everybody in the organization, including all of you at that time. And we managed to do a lot of improvements, reducing waste, improving efficiencies, and in fact, from 2016 to 2020, and you would have not necessarily known about this through some processes around best practices, we were able to save over $200 million without laying a single person off. It's pretty impressive, and obviously the strategic clinical networks were a key part of that. This is a really nice framework from the integrated care model. It's from the International Foundation of Integrated Care, which is a non-for-profit membership-based foundation whose goal is to act as a leading voice in advocating integrated care through proactive collaboration. And it's a nice framework that people can utilize. I can see when I look at this, there are aspects that we had within AHS at the time, and some aspects that we were probably not as good in. But just to say that in 2018 at the International Conference on Integrated Care, AHS was named one of the top three most integrated healthcare systems in the world, and in fact was ranked second as the system that everyone wanted to learn from. So we're very proud of the fact of all the work that was done to actually result in that type of recognition. So after saying all of this, so what? You know, I've just presented you the challenges, I've given you what I think would happen, and we know that there are some really good examples, but I wanted to share with you a particular example, and some of you would have known about this community. This is the South Central Foundation NUCA System of Care. It's a non-for-profit health system that's owned and operated by Alaskan Indigenous people. It is for Alaskan Indigenous people, and it started back in 1998 with an integrated system that delivers a broad range of services. And since then, there's been more services that have been brought in. It's had the same vision and mission and goals for more than 30 years. And again, that comes to that short-termism. We need long-term vision for the journey to success for any sustainable system. And so this is more than 30 years. And the vision and mission are linked very closely to what the community values, to what the community traditions are, what the culture is. And their corporate goals are three themes: falls under shared responsibility, commitment to quality, and family wellness. And the case for change started actually in the 1960s, sort of escalated to 1980s, where there were a lot of issues that were not just within health domain, but resulted in a lot of health issues. And in 1998, they had the chance to redesign the care system, and it started with primary care in the center. That was where the focus was. In 1999, they actually then assumed ownership of the hospital. They chose the model of a highly capable hub for medical behavior, social issues for everyone, with a very inclusive care coordination model. And they moved away from a medical-centric model to a person-centric, and they leveraged the shared responsibility where the office visit must be replaced as central. You can see here that this is sort of the framework by which they used, but I just want to highlight in the center, you notice that there's a sort of a person figure there, and it actually talks about a customer, owner, and family. So they actually changed the language and where they no longer use the term patients, they used the term customer owners, and that came soon after they were formed in 1998. And it's taken multiple dimensions as a consequence of the change in the name. It reminded patients that they should treat the community as customers rather than beneficiaries of care, which is what we do all the time. It signals the expectation that people should assume shared responsibility for their well-being, and it reminds the community of its role as a shareholder in their health system, with a right to have pride for shared successes and a responsibility to sustain it for future generations. Another really important aspect, when they changed the name to the customer owner, and when they actually did another survey in 2015, so this would be 17 years later, 96% of the customer owners said that they were involved in the decision about my care. I don't know what happened to the 4%, but 96% is pretty awesome. And so it is really about a system where it is about primary care, same-day access. There's no such thing as wait. There is same-day access if you need it. And what they do is they bring the services to the primary care setting, right? So it's not about sending people for specialty services. It's about bringing the specialties to them. It's not about sending them away for psychotherapists if needed. The psychotherapists are there. So all the services are centered around the primary care model. And when you think about who makes the decisions, it's based on level of acuity. So if you're low acuity and it's, you're in the clinic, it's a higher likelihood that the customer owner is going to be making the decision. And obviously, as the acuity goes up and the medical care becomes more complex, then that's when the specialists and the providers actually step in. They have integrated multiple aspects of what it means to be a learning system around investments in improvement advisors. They've got developmental courses. They've reduce their variation of care. They've got a standardized database for 30 years that allows them to measure outcomes. And they've got dashboards and scorecards for all different providers that are in the system. And they've got multiple projects with executive sponsors. Reminds me of SCN, say, Tracy, a little bit. And so what are the outcomes? Well, the outcomes are pretty impressive. So not only have they reduced the load on the acute care system, look at their ED visits, reduction in hospital admissions, reduction in referral to specialists. They actually have also, because of the focus on wellness, they've also reduced the burden on primary care. They've also got best clinical outcomes. And look at their customer owner satisfaction and their employee satisfaction. Any organization, not healthcare, any organization with a 95 to 97% satisfaction, they got to be doing something right. And then the dollars that they save from the reductions in usage of the system are they're invested back into the system for continuous improvements. So this is not meant to depress you, but just to say that, 1 out of 10 Canadians really have expressed confidence that the system can do capacity to meet those evolving needs. So not a lot of Canadians feel confident of the system. And in fact, there's a staggering 31% who've indicated they have no confidence in the system. What I'm trying to say with this slide is that, the raison d'etre is there. Canadians know the system is not where it should be. They know that it needs to be fixed. So we need to really be ready for whole-scale change. This slide is a really interesting slide. This comes out of polling research by Jared Wesley, who's a political science professor at the U of A. And if change is going to happen, who's going to drive the change? And the question is, if it's not us, then who? Look at the levels of trust. And actors just means sort of professions. Nurses are at 90.1% for levels of trust. I'm assuming this is not just Alberta, that you can probably extrapolate this to the rest of Canada. Physicians are 86.4%. Now, for some reason, transit operators are at 81.9%. So I don't know, if you take the buses, have a chat with your bus driver. But teachers are at 79.1%, professors at 75.2%, and not surprisingly, politicians are at 20%. I always used to say when I was leading HS that, because at the time that we started, there was still a lot of doubt about the organization. And I always said that, if in one day I could convince just one person to give HS the benefit of the doubt, that would be a successful day. And I feel that we may be back to those times. So how do we mobilize for effective change? Well, really, it's about refocusing on transformative innovations versus really trying to improve a declining system or having incremental. I don't think we can do incremental anymore, not with the current state. And it really is about making sure that we have a common purpose, common goals, common values that can actually help guide us to drive the actions. And it has to be really patient-centered. What is really key to looking at some of the successful systems is the ability to engage not just government, but non-government subsystems to really embrace the goals for the sake of the well-being of the whole community, and that's where we're at. I had the pleasure of listening to a talk given by an individual named Paul Bourne, and Paul wrote a book called Breakthrough Community Change. It's a guide to creating a common agendas that change everything, and in this book, he shares his methodology for large-scale community change. And what I like in particular about Paul is his real-life experience and how this method has been tested not only in Canada, but in the US. And he writes about his experience. He was very involved in trying to end poverty and how he was able to bring an interconnected force and ultimately resulted in some large-scale breakthrough community change. And it's really meant to inspire community leaders, social service providers to really consider solving the root causes of problems rather than simply addressing the symptoms. So now that we have the prescription, how do we mobilize for effective change? And sometimes we risk putting system-wide transformation into the, it's just too hard basket. And then it becomes paralyzed because we don't even know where to start. So I ask myself all the time, where do we start? Well, we have to start with ourselves. We have to start with each other. And we have to ask ourselves, what is our North Star? What is important to us, as a Canadian, as an Albertan? What is important to us when it comes to health and our healthcare system? And then we have to have a dialogue. I always say also that if you throw one rock into a pond, there just may be a few ripples. But if you throw enough rocks in, the ripples hopefully will create a big enough wave for change. And I think, the Sai legacy of tenacity and never giving up, I think we owe it to Sai to continue his vision of having the best healthcare system ever that we can create together. And so I love this vote that I'll just close with, which is, most of the important things in the world have been accomplished by people who have kept on trying when there seemed to be no hope at all. It's a quote by Dale Carnegie, but I think Sai would have said this also. So thank you very much.
It's tremendous and on point, thank you. I will just open your first question. So your presentation highlighted that all aspects of our healthcare system have to change to achieve integrated care. And it was, where do you believe we start? So with you, how do we get you back?
Really? That's the question? Yeah, I mean, I think one of the issues that when I think back around AHS and why AHS was so easily broken up was because we didn't actually have the public support or the public understanding about what they want. And that's the issue for Canadian healthcare, is that we as Canadians have to understand what we want in our system. And I use the Alaskan South Central example because they'll never break up, because it is driven by the customer owners. They own the system. And so it's not even a conversation for discussion. The conversation is, how do we make our system better? And part of our challenge is that when we talk about healthcare, we talk about healthcare from the provider perspective and not from the customer owner perspective. And that's where the dialogue has to start. And it's going to take time. Like, there's no quick fix here. But if we want our system to be sustainable, I've got grandkids now for my grandchildren, then we got to start the conversation. And remember that trust percentile. We are the most trusted amongst the public, so we have to have those conversations. How we do it really is up to you to think about how we do it, but we've got to have a social movement here about the healthcare system that we all care about.
A reminder to use Slido to submit your questions. There's one other one here. How can universities help the government of Alberta with the learning health system implementation?
I'm going to sigh a little bit here on that one. How can the universities help? Well, you know what? I think we need to be able to change the language in which we talk. So it was interesting coming back to the university. I rejoined the U of A back in 2022. And, I love my colleagues, right? I mean, my career started as an academic, took a bit of a, 10-year stint away and then came back. But, as academics, we don't talk the same language. We don't talk the same language as the public, let alone government. And so we have to change how we relate and how we are relevant to the dialogue so that we can actually help some of that. And I think we have been successful. I've seen how we have been successful. There have been certain bills that have come across our paths where we've really tried to engage government in a way to say to them, listen, there are some major unintended consequences that you are not aware of, and this will not work out well if you continue on the same path. And we've been actually able to make a difference. So I think from the administration part, it's really about how do we actually talk the language in a way that actually helps people understand. I think when it comes to the public, remember academics, professors were also highly trusted. And again, there's opportunities for academics also to have the conversations, but it has to be done in a way that's not divisive. It has to be done in a way where it's open to the other dialogue. And it's very problematic to have that safe space. People don't feel safe to have conversations. And universities can provide that safe space. And I think both U of C and U of A were trying really hard to not get pulled into any of the political divisiveness, but really to try to provide those opportunities where you can actually have informed, open conversations about very important global challenges that are not only facing Canada, but the world, so.
Thank you. So one person has asked, do we need permission or can we just get on with it and do it? And what about the politics?
Well, I think if we waited for politics, we never get anything done. So I give you permission. Go out and do it, right? You know, I think it's tough times now. You know, I've said to many who work in healthcare, I mean, physicians, we're fortunate. We've got always an ability to work in the clinical realm, and you know, but there are others who don't have that opportunity. So it's tricky, I would say, right now. But we all have personal networks. We all have professional networks. We all have an ability to connect with people. And these are conversations that we have to start having. And if, you know, I personally wouldn't ask for permission. I think once you start doing that, then more likely than not, the answer is no. And if you don't want to hear that, then don't ask the question.
What about educating the public and the government about our visions and our ideas and these models of other healthcare systems to look at?
Yeah, I mean, absolutely. I think the public would be, I mean, one of my other, it's not really a pet peeve, but I guess it is it's really about health literacy for Canadians and how it's not very good, I would say, in general. I think COVID has actually elevated the level of health literacy, but almost to a point where it doesn't make sense, right? So, but you know, I do think the public needs to be educated for sure. There's always that opportunity. We live in a university setting. We should be educating our students. You know, they are a positive force, you know, for our future. And so really it's about how do we get that message about the types of systems that we can have. It's hard right now because it's muted, right? Everything is very quiet and nobody really talks about things and it's very localized. Everybody wants their own little hospital back and, you know, it's very counterintuitive. But I think if we can have these conversations, as I said, in sort of safe, neutral areas like universities, then that's where we need to bring some of that awareness. It's not easy to do by any means, but I think it's our responsibility as, you know, as an institution.
And then I guess just following on that, what about the current government's focus on rural voters, and how do we start to think about alignment with that agenda perhaps, and also with rural Albertans to create support and understanding for this?
Well, you know, one of the big things that we always try to do, and SDNs were very critical to that, was reducing variation of care in the province. You know, I always said that, you know, if we are true to being a truly integrated system, you know, we should have the same care no matter where you live in Alberta. And that extends not just, obviously, Edmonton, Calgary, where you have all the specialists, but even the remote rural areas and parts of the province. And for the rural communities, it's all about access. It was very interesting. We heard it loud and clear that they're not that interested in quality of care, which is very interesting to me because I would have thought quality of care is more important, but actually for rural communities, it's all about access for them. And so again, you know, once their hospital doesn't have their emergency rooms open because they don't have enough staff, you know, I think that's the time when they probably will listen more to the challenges of healthcare. But, you know, I would like to think that when we talk about the common goals and the common purpose, that it doesn't matter where you live in Alberta, that it would resonate with everyone. I think that's what's really important, is that we shouldn't really be making distinctions about rural healthcare or rural this. For me, that just adds more divisiveness. If we can come up with a common vision, healthy Albertans, healthy communities together, like what better vision is that? I mean, that really talks about everybody in the province. And, you know, I would like to think we can garner all the voices at the table, which includes both rural and urban populations.
All right, right, and then our final questions here, there's a couple I'm going to combine, but it's about, as voters, how do we become more educated? How do we educate other healthcare professionals around these issues and amplifying the message? How do we do that?
Well, I'm not a politician, so I can't, you know what, I think you guys need to, I think people need to be informed. Like, you know, we live in, I would think, one of the best countries in the world, from my perspective. We live in a democracy. We have the freedoms to have a democracy. I think it is our responsibilities as a Canadian to be informed and aware of every election and for us to participate in voting. I actually was very disappointed in the turnout in the last election. For such a pivotal time for the province, it was a very low turnout. And, you know, we need to garner everybody. You know, all my kids voted. I made sure everybody in my connected to me voted. And I think, you know, I would encourage all of you to make sure that you encourage everybody around you to vote, because every single vote is important. And when you don't vote, that means you're voting for status quo. So just want to say thank you again. I really enjoyed my time here, and look forward to continue chatting into the future. Thank you.
The final question that actually snuck in was just to thank you for your inspirational leadership and how you're inspiring and also giving us resilience through your efforts. So thank you very much, Dr. Yu. All right, so we're coming to the conclusion of our event, but we have one last person to invite to the stage, and that's Dr. Jason Worley. Dr. Worley is an orthopedic surgeon, a clinical professor and section chief of orthopedic surgery at the University of Calgary, and he's also a member of our planning committee for today's event. He's recently the executive director for the Institute of Improved Health Outcomes and president of the Canadian Arthroplasty Society, and he'll be giving us some closing remarks and thoughts on today's presentations. Dr. Worley.
Thank you, Cheryl, and thank you for this opportunity to provide some closing remarks to this amazing Cy Frank Legacy Lectureship. Cy Frank. It's remarkable that when we hear Cy's name, I'm sure many of us feel emotions of admiration, respect, maybe even reverence. And we've heard of many descriptors today for each of our relationships with Cy. Surgeon, colleague, researcher, mentor, visionary, but to all of us, a friend. Many of us attending today are in our current career or station in life because of Cy's influence in one of those realms. And it's remarkable to me, and I'm sure many of you, that 10 years after his passing, the admiration, the respect, and the reverence is as strong as it was a decade ago. As we heard from speakers and panelists today, Cy's legacy continues to have an incredible impact on each of us, our work, and most importantly, patients with bone and joint diseases throughout Alberta, Canada, and the world. As section head of orthopedics, a position that Cy held for 14 years, I often find myself asking, what would Cy do? Or what would Cy think? And so Cy's influence continues to this day. This year's lectureship program was designed to highlight all the areas of Cy's impact, and I'm sure you'll agree that all the lectures and panelists delivered. The 10th anniversary Legacy Lectureship was supported by the McCaig Institute for Bone and Joint Health, the Cummings School of Medicine, the Section of Orthopedic Surgery, the U Calgary Alumni, and Alberta Innovates. I'd also like to thank the friends, family, and colleagues of Cy who have contributed to the Cy Frank Legacy Lectureship endowment. Without your generosity, this event couldn't take place. We continue to welcome donations to ensure this lectureship can have an impact for years to come. If you're interested in continuing contributing to future events, please reach out to the McCaig Institute for information on joining our planning committee. Now some specific thank yous. Thank you to our keynote speakers for their insights today. Hani Al-Gabalawi for your discussion on the return on investment in biomedical research. Verna Yu, for your thought-provoking presentation on Canada's healthcare paradox. Thank you to Braden Mans, Kristen Barton, Nick Motati, Deborah Marshall, and Tracy Wasilek for your commentary on healthcare leadership, orthopedic research, and Alberta's learning health system. Thank you to Gareth Ryan, recipient of the Cy Frank Rising Innovator Award, for your inspiring talk on fracture healing and biomarkers. Thank you to Diane Mosher and Cheryl Barnaby, as well as Marv Fritzerler, for your leadership in organizing the lectureship over the last decade. And thank you as well to the other members of the organizing committee, Marilyn McCaig, Deborah Marshall, Tracy Wasilek, Raja Mehta, Judy Crawford, Tim Murphy, Prism Schneider, and Martin Ferguson Pell. This event would not be possible without the support of the McCaig Institute for Bone and Joint Health, and in particular staff members Yvonne Durnan, Stephanie Symington, and Karen Leinhardt. Thank you. Finally, I would like to thank each of you for your attendance and for continuing Cy's incredible impact and work into the future. I, and I'm sure all of you, are looking forward with hope to the next 10 years of Cy's legacy. Thank you and have a good evening.